Good morning, everyone. My name is Riyad Abulab, and I'm the Scientific Director for the BC Emergency Medicine Network. And it's a real honor for me to be here today with you at this important event. I'd like to start by acknowledging that I'm coming to you today from Vancouver, very near the Point Grey campus of UBC, and specifically the traditional, ancestral, and unceded territory of the Musqueam First Nation. And I'd invite each of you, whether you're in BC or outside of it, to similarly consider and reflect on the history of the land that you're on. We've got a great lineup of presentations here in Zoom Room B. That's where you are right now. Hopefully you're in the right room. And I'd like to acknowledge and thank Tracy DeLu, who's in the background helping to keep us organized. Tracy and I will be keeping track of the timing. Just a reminder to all presenters that you have 10 minutes for your presentation, and then we have 5 minutes for discussion. It's really important to try and keep on time with that. We'll do our best to remind you if we go over and are sneaking over, it'll cut into our discussion time. So with that introduction, I'm going to start with our first presentation and introduce David Shiflett and Dawson, who are presenting today from UBC Okanagan, and presenting on exploration of nurses' equity consideration in their electronic documentation.
Well, good morning, everyone. My name is David, and today Dawson Penner, my co-researcher, an undergraduate student here, who I work with at UBCO, and our team, we're going to be telling you a little bit about a research project that we've been working on over the last couple months here. The project is entitled An Exploration of Nurses' Equity Considerations in their electronic documentation. Now, just before we get started, I would like to take this opportunity to acknowledge that this presentation is taking place on the traditional, ancestral, and unceded territory of the Syilx Nation. And of course, we'd like to, before we get too much into the nitty-gritty of this presentation, speak a little bit about our research team, because it's quite a unique group. So an important feature of this project, in fact, is the interdisciplinary aspect of the research team, in which we've really gathered researchers from a variety of educational backgrounds. The diversity of this team allows us to incorporate different insights that might not have even been possible otherwise. So our project here is about health equity documentation AI. What is artificial intelligence? Artificial intelligence can really be thought of as the science and engineering of making intelligent computer programs. In healthcare, artificial intelligence algorithms are usually embedded within computerized clinical decision support systems or risk prediction calculators. Clinical documentation from electronic health records are really the data that feed into these artificial intelligence technologies for health. Crucial characteristics of these data that will determine what can actually be done with these algorithms include the data quality, the data quantity, as well as the format that these data are actually captured using within the electronic health records. Now, a challenge with clinical documentation in electronic health records is the potential to transfer implicit clinician biases within documentation. For example, there's evidence that clinicians that they may not even collect data as consistently about some population subgroups versus other subgroups, and this really results in the problem of missing data. Now, in the context of health equity and making sure that information about individual social determinants of health and social contexts are captured, there is then the question of how clinicians think about health equity. What counts as health equity? What counts as health equity data? How is health equity documented in electronic records, within these electronic health records, rather? So another challenge relates to how electronic health records and organizational policies around documentation potentially shape how clinical documentation is compiled. For example, there's actually evidence that electronic health records designs are really quite a poor fit for the needs of the nursing practice. As well, we know that the concept of health equity is fairly complex. In turn, how and where do clinicians manage to document this in electronic health records? Given what we know about the role of data in shaping artificial intelligence possibilities and the role of electronic health records in shaping clinical documentation, an important step towards building equitable artificial intelligence is the integrity and those characteristics of the data that I mentioned. The current state of healthcare documentation has an inherent bias around various marginalized groups. Historically, these disparities have arisen in groups of different ethnicities, different races, varying age, varying sex, physical ability, amongst other demographic factors. These biases result in an insufficiency in the quality of healthcare that these individuals receive, both the past healthcare that they had received and then also healthcare that they could receive in the future. In turn, these inadequacies can actually cause patients to, case in point, avoid pursuing healthcare in future events. We are trying to tackle clinical documentation in the hopes of building an equitable artificial intelligence algorithm because biases in clinical documentation are really evidently the root cause of this problem. Our project will establish the foundations for a larger program of research that will leverage the use of community health nurses' clinical documentation in order to build artificial intelligence technologies that are able to incorporate health equity data. Now, in order to get to that endpoint, though, we must start with the data and understanding how are data produced and documented by clinicians. We focus on community health nurses because they're really the profession who, they're an example of a profession who spends a lot of time with patients and actually in quite a personal setting because they're generally in patients' homes. This gives community health nurses a fairly unique vantage point where they witness the lived experiences of health equity considerations, including housing, socioeconomic status, experiences of both privilege and marginalization. These are amongst many other factors that shape health and wellness outcomes. Yet the question still remains as to how these health equity considerations are conceptualized and captured by community health nurses. And to tell you a little bit about that, I'm going to hand the floor over to Dawson.
Hello, everybody. Thank you, David. So I'm Dawson, one of the undergrad students who is also helping work on this project. So I'll continue us along here. So to start, we need to start with the data. So in our data, our research is seeking to A, understand how community health nurses are thinking about health equity. We're also seeking to understand how community health nurses are going to document this health equity, and as well understand how the design of current electronic health records are shaping clinical documentation. These factors can then be analyzed to see their effects in past healthcare and can be used to improve future patient interactions. A key objective of this study is to develop a dictionary of health equity language that will eventually be used to develop an artificial intelligence algorithm. So let's talk about the methodology real quick. In order to develop the understanding of our data and our health equity dictionary, we will conduct a qualitative interpretive descriptive study as this supports an approach that is flexible, practical, and solution-oriented. As our interest is to understand how nurses conceptualize health equity, we aim to recruit nurses across different populations and geographic settings. We will be conducting individual interviews with community health nurses online, and we will be recruiting these nurses from the Interior Health and Vancouver Coastal Health Authorities. The type of data analysis that we will be doing will be immersive and iterative, and it will be conducted concurrent to data collection in order to allow for constant comparative analysis. Basically, what this means is that we will be iteratively drawing insights from the interviews that we are doing, and we will be using that to refine the next interviews to make them even better. So the reason for using interpretive description is that it offers the unique aspect of incorporating collateral data, which is basically additional data sources to support a better understanding of what shapes community health nurse documentation. The collateral data that we will collect in this study includes current clinical documentation policies that guide how nurses complete documentation, the data entry fields and designs of both the Paris and Meditech electronic health records, which are currently being used in the Interior Health and Vancouver Coastal Health regions. Another thing is we'll also be looking at special considerations affecting documentation that may be identified while we are hosting these interviews. Here, before we conclude, we'd just like to review the larger picture of this research again. As mentioned earlier, the aim of the study is to establish the foundations for a larger program of work that aims to develop equitable AI for health. The resulting health equity dictionary from the study will serve as the gold and standard corpus, or the body of language that will be used in later studies that will aim to pull these health equity phrases, languages, and data from electronic health record documentation. And this is being done in order to build health or equity-informed predictive risk algorithms. So here are just some references from what we used in our presentation. And then just before we conclude, I would just like to make a few acknowledgements. We'd love to thank all the primary investigators of our project, which are Drs. Lee, Shao, and Ronquillo. And we'd love to give a special thanks, especially to the whole MRF program and its facilitators for allowing us to all be brought together to work on this project. Now, I'd just be pleased to open the floor to any questions from you guys, and I would just like to thank everybody involved in the conference.
Fantastic, fantastic presentation, David and Dawson. It's always tough to go first, and you guys did a great job. Really an interesting and important project.
Right.
I'll just remind everybody that it's the Zoom chat feature that we're using for questions or comments. So if you have anything, please submit it there. So there's one question asking if you have an example of a health equity data that you might expect to collect.
Yeah, I'll take this one. So basically, that's a good question. It's like the basis of the whole thing. So we should definitely be understanding that. So basically, the type of data we are going to be collecting, we are going to be talking to these health nurses and seeing like how are they documenting, like basically in an electronic health record, there's different fields, like you can like select different boxes, or you can like type out long answer responses. So we want to be seeing how community health nurses are writing basically on, especially on kind of those marginalized groups that we were talking about earlier, whether it's like various age, sex, cultural groups, people with different disabilities. We want to be seeing, are they using specific languages in order to document how they're treating these patients? Because the language they're using, it can even create a bias that they might not even realize. So we want to see how are they documenting that, and how is that then coming up again later on when they're treating these patients again.
There's some great comments appearing on the chat, and I can already tell that we'll frequently not be able to get to all the questions. So, I will remind presenters as well, one option is also to answer questions that you haven't been able to answer in your presentation in the chat feature as we kind of move along. I'm going to go to one other question for the two of you just before we move to our next presenter. And there's a question on from Tracy on how you'll actually select the community nurses for the interview. What's your process for selecting that sample? And I noticed you've got two groups, right? Vancouver Coastal and Interior Health.
Yeah, no, that's a great question. So currently we're at the very beginning of our trials, so we haven't selected those groups yet, or we haven't actually sent out the invitations and that kind of thing. But the main idea is we're going to be just kind of like posting some advertisements at within both these health authorities, either like at the hospitals or sending them directly to the health nurses that are involved in those communities. And that's how we'll be reaching out to them. And then from there, it's just obviously volunteer based. Whoever wants to host an interview with us, we'll be setting up a Zoom or some other meeting like that and hosting it through there. I hope that
Yeah, it's an important thing to think about. I'd encourage you to just give some thought to that, because the sample that you get and the representativeness of it is really important as far as the results go. So again, great job. I'd ask you guys to stop screen sharing. And we're going to move along to our next presenter, Dr. Tracy Morton, presenting on the Rural POCUS survey.
Hello, it's Tracy Morton calling in from Haida Gwaii. Are you just a sound check here? Is everybody hearing me?
We're good, Tracy.
Okay, great. And is the screen being shared appropriately?
Screen is shared. You're not on slide view anymore. There you go. Yeah, that looks good.
Great. Well, good morning. I really want to express my appreciation to the organizers for holding this conference and accepting our proposal for presenting here. I see there's 3 POCUS point of care ultrasound presentations. So it seems like a hot area of research in rural BC, and actually in medicine in general. So I'm presenting on the Rural POCUS survey, trying to answer the question ultimately of what do BC's practitioners need to be skilled to use ultrasound with their patients. So my name is Tracy Morton, and I'm calling in from the Haida Gwaii and representing the Haida Gwaii Hospital and Health Center. I also have a role with RCCBC as the co-lead for the POCUS strategy that RCC's embarking on. Earlier this year, we commenced this strategy. So I'm presenting from the territory of the Haida Nation, which is my home and work, and also want to recognize that RCCBC conducts its work on the territories of more than 150 First Nations across the landscape of BC. So what is POCUS? Some of you may not have heard of this term. If you haven't, you're going to hear about it a lot more, I hope. It really refers to when the clinician, the treating clinician, him or herself, uses ultrasound at the bedside, usually during the first assessment. It's known, according to the evidence, and certainly according to those that use it, that it provides very quick and at the bedside diagnostics. It saves other forms of imaging, and besides improving diagnostics, there are many, many procedures that can much more safely be accomplished with less complications with POCUS guidance. So it's using ultrasound to help with the performing of the procedure. I just want to show you an actual, live image of what it looks like. This is actually my heart. I'll just play it again here. This is looking through the chest wall at images acquired in real time, either still images that you can pause and have a look at, or live images in video format that can be saved and viewed, and certainly lots of information can be acquired through use of just directly visualizing the structures of the body. So this particular clip was taken with this handheld device. So you can see that the concept of ultrasound has really advanced substantially over the past 10 to 15 years with miniaturization and increasing technology, such that something that would fill half a room in the 1960s is now something that could fit in your pocket. So this is what's called a handheld ultrasound. So why would one want to study POCUS in rural BC? Well, RCCBC is embarking on what's called the Rural POCUS strategy. So how can we understand the barriers to using ultrasound? What are the attitudes that both generalists and specialists in rural care have around its use? And ultimately, what supports can we put in place to improve both the skills of providers, as well as address some of those barriers that they identify? So it was felt early on when we embarked on this project that we had to come up with some sort of data to help guide us as to rationally design programs to support clinicians. So these are some of the targets for who might want this kind of information. So there's the RCCBC itself. There's the Faculty of Medicine at the undergraduate and all the postgraduate residency levels. Also applies to things like midwifery and nurse practitioners and even nurses themselves who may want to be using POCUS in certainly hospital and clinic settings. There's UBC CPD, and then there's all the health authorities themselves. So there's a large number of groups and organizations, institutions that we feel could benefit from a survey. The PIs were Virginia Robinson, who's my co-lead for the RCCBC POCUS strategy. She's out of Fernie. There's myself and Dan Kim, who's the Canadian Association of Emergency Physician ultrasound chair. It's a mouthful. He's a very accomplished researcher in POCUS based at Vancouver General Hospital. And we also have Jason Curran and Paul Osinski out of Saskatoon, who also an accomplished researcher as well. So we've got all these folks have assisted with survey design. I want to give special acknowledgement to Tracy DeLu, who is helping out in the back of this, probably you've seen through email, but she's also the POCUS coordinator and our research coordinator as well. Has been instrumental to getting the survey launched. So this is a bit about our design. We only use Qualtrics, which is a digital survey tool, no paper copies of any sort. We used a mixture of Likert scales and ranking for folks to comment and give opinions on certain statements. Mostly we created quantitative responses only for ease of analysis. Our recruitment base was about 2,000 rural physicians. Ethics was acquired and we launched in September. We had funding from RCCBC itself, and we also have a flex student. It's a medical student, a senior medical student that will be helping soon with data analysis. So we wanted to ask who is using POCUS and where in the province and for what things it's being used for. How have people acquired their POCUS education? What do they feel their supports required are? And what are people's thoughts on image storage and archiving for quality purposes and documentation purposes? So we're still in data collection. We've got about 231 responses, so less than what we had hoped, which was in the 500 to 600 range. I'll just give you a preliminary review. This is sort of early data, first time showing it. These are some of the health authorities that have responded, with Interior and Northern being the highest response rates. And this is some of the range of sizes of communities. So fairly small, under 10,000 was the majority, but some 10 to 20,000 and several quite small communities. These are not your typical rural clinicians, because these are folks that self-identify to be using POCUS very frequently. So sometimes several times per shift. You can see the majority. So we're not sure that this is capturing the average rural clinician. Certainly with this question, when you perform POCUS, how often does it provide information that changes clinical management? Generally, the literature states that it's about 25% of the time, but these are, I think the folks that have responded are certainly seeing and reporting on that benefit, but even at higher rates than what the literature shows. So, up to half the time, and the largest cohort here find that it is changing clinical management. This question, rank the order of how you could be supported to use POCUS, and we listed a number of things that they could choose. Funding for courses was the number one, ranked 3 with 1 being the most important. So this was these numbers refer to the relative ranking on a list of 10 different choices. So things to do with training, both funding and provision of courses. Funding to purchase a handheld was rated quite high, and a fee code for POCUS billings, which would incentivize the work and the time that it takes to get POCUS competent. So some preliminary thoughts, and I'm sorry if I'm zooming through here. Our response rate is low, mostly, and it's mostly from those already using. And POCUS is contributing meaningfully 25 to 50% of the times it's being used, again, from those that are probably higher users. Supports that are needed have been identified as being mostly educational and financial. Just wanted to show you what an actual teaching session looks like. So this is a peer, this is a medical student teaching session that we did in early October. This is a medical student lying on and you can see this is what one of these bedside ultrasound machines look like. This is looking at an individual's heart here. So maybe I'll pause here. Hopefully I'm on time. I just wanted to open up for questions and say hawa, which is Haida for thank you for your attention. And yeah, should I stop sharing or what should I do at this point, Tracy?
I think you can stop sharing, Tracy, and thanks. That was a fantastic presentation, and you know, congratulations. This is important work, and that's actually a really big sample size that you've got. It's really impressive. Everybody, keep your eye on the chat function because sometimes questions that are asked are actually answered there. There's been one question about the future vision that your group has, which I think is to see a future state where all rural patients have access to a competent POCUS practitioner. Maybe I'll ask one question just while we're waiting to see if others come in. You've got a wealth of data there and a lot of interesting sort of demographic information on, you know, communities and things like how often they're using POCUS on their shifts. Have you given any thought to kind of digging into that secondarily a little bit, looking at factors associated with more use or less use? Because there's certainly the potential to do that with the data you collected rather than pooling it all.
Yeah, so we wanted to do some covariate analysis. By that, I'm meaning maybe like for those that are avid users, are they younger? Are they practicing more rurally? Do they have longer transport times for access to sophisticated, like typical consultative imaging? I mean, we certainly have the sense that that's the case. You know, speaking personally from our setting, it's a full day ferry in each direction to access a simple ultrasound. So you can imagine the motivation that gives you to undergo the, you know, many hundreds of hours of training it takes to get some competency. So I think remoteness is going to be probably the major factor in use of it. And we have the ability within the survey in our, you know, demographic stratification of those who, not just based on health authority, but how remote they are from a typical ultrasound or CT. Our hope is that the strategy itself is, you know, ultimately going to address some of the healthcare inequities, both in First Nations communities as well as rural communities. And you know, I've been here 20 years and I can't think of anything more powerful at improving, you know, really rapid diagnostics and safety of procedures than POCUS, because we just don't have ultrasound, and we've been hoping for a CT, but it won't manifest anytime in the next decade or two. So this is our next best attempt to improve things. So sorry, I was just to stop talking and answer more questions here.
No, that's fantastic. And it's great work. And I think, as I said, you've got a wealth of data there with the amount of things you've collected. You know, there's a comment in the chat about how POCUS is kind of like how one would use a stethoscope. And I think that's been sort of said a lot. You know, there's some questions about, I'll maybe throw out two quick questions for you and we'll stop it there. There's one about whether you might see a future where POCUS ultrasound is a requirement in all EDs. That gets into the interesting politics of you know, what are the standards in our EDs? And there's another question about skill maintenance. And are you looking into that? Because that could be harder in a smaller community where you might use it less often.
Yeah, I mean, I think what we're doing already is you know, what's come through in some of our initial discussions is that we have to hit medical students and develop this as, you know, you mentioned the stethoscope. So there's a course called Clinical Skills, which helps one learn how to use a stethoscope. Well, we're advocating quite strongly with the UBC Faculty of Medicine that every medical student should actually replace their time learning to use a stethoscope with use of a bedside ultrasound, particularly considering the cost of some of these machines are so much lower than historically. And it's just so much more powerful. It's been difficult to make headway because of the inertia associated with undergraduate curriculum. but certainly we'll have better success at the residency level for those residencies that obviously like emergency or family care, family medicine, but things like anesthesia and surgery and orthopedics and pediatrics and obstetrics. There's several specialties that this can be, well, incredibly powerful.
Yeah, great comment. It is amazing that we're using a device that was invented a couple hundred years ago. And it's actually harder to use in some ways, that stethoscope, than an ultrasound when you learn how to use it.
Mhm.
I think we'll stop there, Tracy, just because of time, but do look at the chat function and feel free to write some responses to the other questions that have appeared. And thanks again, congratulations on this work. So we're going to move on to our next speaker, Dr. Jude Cornelson. Speaking about support for rural generalist practice and the efficacy of POCUS. And this is part of a series of 3 presentations in a row on POCUS. It speaks to the importance of this and the research going on with it. Sorry, is it Judy or Jude? I'm really sorry if I pronounced your name wrong.
It's Jude, it's fine. And I'm just waiting to share my screen.
Okay, sounds good, Jude, thanks.
Perfect, thank you so much. And it's really nice coming after Tracy's presentation. I really appreciate having the capacity to build on some of the excellent work that's happening around point of care ultrasound, especially in rural settings. So just very briefly, I'm coming in with a lot of gratitude from the Coast Salish Tsawat Nation, also known as Salt Spring Island, where I've lived for the past 22 years. And I don't have any conflict of interest to declare. The study that I'm going to talk about, the evaluation of the InPOCUS program, was funded in part by Intelligent Network for Point of Care Ultrasound and also with additional funding from the RCCBC. So Tracy's already kind of gone over this, but we've done a scoping review of the literature, and interestingly, increasingly, ultrasound is being used as part of clinical practice among many clinical specialties, but including general practice or family practice. Although it's estimated that currently about 5% of family physicians are trained to interpret scans. As a portable, as Tracy said, a portable handheld device, POCUS provides real-time feedback, which is particularly pertinent in a rural context where access might be constrained to imaging services due to gaps in rural healthcare infrastructure. Rural physicians often have to transfer or refer patients out of their community for diagnostic imaging, particularly after hours. And this can cost up to $20,000 for an urgent transport for imaging. So we have a lot of health system costs when we have to transport out. Consequently, though, because of the lack of local imaging, rural patient studies have shown that rural patients often experience delays in receiving timely diagnosis and treatment. There's also been lots of literature coming out recently on the efficacy of POCUS in rural general medicine, improving clinical decisions, in patient management, in primary care settings, in emergency settings, and a lot around obstetrical care. Data's coming out from Australia, New Zealand, Denmark, and the United States as well, now in the Canadian context, which is fantastic. Moreover, the affordability of POCUS, of portable POCUS probes, makes ultrasound increasingly accessible to rural practitioners. There are some challenges to implementation. So despite the benefits of point of care ultrasound, numerous studies have continued to note the limited uptake. 72%, there was a study done in Whitehorse in the Yukon, 72% of rural GPs stated that incorporating point of care ultrasound into their practice would positively affect patient care and include clinical decision making. However, there was lack of training opportunities, lack of available probes, and also lack of personal confidence in performing POCUS scans, which has been kind of challenges in incorporating into practice. So we have an opportunity right now to look at the uptake of point of care ultrasound in rural BC to increase ultrasound capacity. The Joint Standing Committee on Rural Issues have provided funding through the RCCBC to support rural family physicians who want to include point of care ultrasound in their clinical practice. So with this funding, 60 rural GPs across BC have been issued ultrasound probes and training. And they've been asked to upload images, etc., cetera. And so this is the program that we're evaluating through the Center for Rural Health Research, and what I'm going to be talking about. So the point of the evaluation was to look at, we're broadly interested in the experiences of those who have received the probes and to understand the perceived value to rural practice. We've done 22 virtual interviews and have analyzed the data. So the next screen I'm going to show you is certainly not meant to be read. It's just to say we've gone through.
Sorry,
Yep.
can I interrupt? We're not screen sharing right now. Have you, do you want to try that again? Just make sure that we can see your screen.
Yep. I'm so sorry. I started screen sharing. Did you ever get some of the screen share?
We weren't getting it, but you know something, your explanation was so good. I wasn't sure if you were waiting to start sharing. So it's not a problem. We're seeing it right now. So that's
Okay,
good.
I'm so
I
sorry
think
about that.
we're
It
on
did cut out.
track
I'm
with-
really apologizing.
No, no worries. Thanks.
Okay, so we did do a kind of thematic, rigorous thematic evaluation, and it was really great. The responses we had were fantastic. I'm actually not going to go into that right now, but just to say that the overarching take-home message was that, as Tracy kind of intimated already, that point-of-care ultrasound is incredibly important. We had lots of quotes about it's the new stethoscope. I can't provide good quality care without it. However, from a systems perspective, we're actually very interested in transformation. In this instance, the diffusion of the innovation across rural BC. So what I'm going to do for the rest of the time is quickly look at the uptake of POCUS from the perspective of innovation theory, using Everett Rogers' theory of innovation that probably many of you have heard about. So this provides an explanatory framework to understand how an idea, a product, or a process spreads through a population or social system over time, with the end result being what we're looking for is the adoption of a new practice. So there's 5 adopter categories, as you see on the screen, each with particular characteristics. I think that with point of care ultrasound, we've gone past the innovators. We're still in the early adopters. We don't have general uptake in the community. And by the way, as you can see, when you finally get to early majority, the end of the early majority, you've got enough system momentum that you kind of have an innovation pathway. We're not there yet. And there's something standing in our way, as Tracy's mentioned, and that I'm going to get to. But anyhow, Rogers also went on to describe 5 elements of an innovation or new technology that will determine the speed of its movement through an adoption phase. And this is really helpful if we're looking at the medium-term impact of point-of-care ultrasound on rural communities in BC. So these elements of innovation I'm going to very quickly go through and then have time for questions. And the first one is the relative advantage. So that's really the degree to which an innovation is perceived better than the idea that it superseded it. And we had a heap of quotes on that. Then the notion of instant access to imaging with instant access to data to make decisions was super important. You'll see on the bottom some of the quotes I was alluding to. It's a game changer for small communities. I suppose I could practice without it, but it wouldn't be the same. So lots of real positive regard immediately about the relative advantage of point of care ultrasound. The second thing I'm going to look at is compatibility, and this refers to the degree to which an innovation is perceived as being consistent with the existing values of the potential adopters. And we heard a lot about this. Almost all participants noted that the use of point of care ultrasound was an extension of their generalist medical training and experience. And this is where it's really exciting that it's become a generalist technology as well as a specialist technology, of course. So participants frequently articulate their use of POCUS as an extension of the physical exam or extending the senses of a practitioner. The sense of compatibility was seen as functional to widespread adoption due to low barrier to usage. Most participants expressed directly their view of POCUS as an extension of known skills. Often this was made evident when they were teaching residents. So the third one I'm going to look at, the third part is complexity, and that refers in general to the degree to which an innovation is perceived as difficult to understand or use. And of course, you would anticipate that the increased complexity is inversely proportionate to uptake. So if things are very complex, they're not usually taken up as quickly. But interestingly, most participants that we talked to noted an ease to the use of technology, but expressed practice setting complexities around ensuring accurate diagnosis. So what that means is many participants mentioned they had to constantly navigate the boundaries up between their training and experience and the subsequent need to maintain an index of clinical suspicion or healthy fear, as one participant noted, around the importance of respect for ultrasound before they start using it. Negotiating this tension came through as a complexity of professional practice with regards to point of care ultrasound in particular. Almost finished, the treatability or trialability, sorry, was the degree to which an innovation may be experimented with on a limited basis. So participants diverged a little bit here about modifications to how to integrate point of care ultrasound into their practice setting. And they diverged on, particularly the one I'll talk to is context of billing. So in the fee-for-service billing, we heard a lot about the valuing and desire for billing codes when point of care ultrasound was used. However, there was disagreement a little bit in there between people who are very adept with point of care ultrasound and felt that billing codes weren't necessary because they were efficient, and those who were starting out, who noted that it took a long time within a clinical interaction to do the ultrasound scan, and they weren't being remunerated for them, it put them behind, etc. We didn't have these concerns at all from folks that were practicing in an alternative payment setting, because of course they don't have those constraints on time. And then, of course, the last idea was observability. And this refers to the degree to which an innovation or the results of an innovation is visible to others. And it's an essential part of diffusion. When the rest of the population sees the value of an innovation, in this case, point of care ultrasound, it diffuses much more rapidly through the population. So, we've already kind of alluded to this. Most study participants, I think, all shared anecdotes of incredibly positive responses from patients due to the immediate information provided to them due to their clinical condition, particularly observed within maternity practice, where patients could, for example, have immediate feedback about the viability of their pregnancy, or at the end of pregnancy, the in utero position of the baby, which makes a really big difference in rural. If you're not sure the position of the baby and someone's about to go into labor, you might not have access to cesarean section. So really, really important positive observable results. Now, that said, I do have to say that, as one participant said, well, I've drunk the Kool-Aid. So the people we were talking to were already early adopters, already very keen. And then the people who actually participated, voluntarily in the research were the most keen of the keen. So we have to just keep that in mind. But, some of the questions the responses that stick with me, of course, were, this is essential to rural practice. I could never go back. There's amazing potential, allows for better decision making. And I put a couple of quotes there on the screen. So I'm going to end there. We've got a few recommendations around based on our data, based on the international data that we've looked at, around the importance of diffusion across rural BC, which is what we're focusing on, and ways to do that. And Tracy's working on that as well, from his end, through educational processes and some social process, some system level processes. And I will end there, hopefully not too over time.
Thanks so much, Jude. Boy, this is such an important topic, and it's interesting to see the chatter in the chat function on it. There was some talk in there on artificial intelligence and the future that may bring, and some work that's already been done. Just in the interest of time, I don't think there's other specific questions, but I'm gonna ask you just one quick thing, and leave it to the chat function to carry on some of the discussion. Any thoughts on kind of the politics of all of this? Some of it relates to things like when you get into things like billing codes, we've got stethoscopes in our hands. We're not billing for using stethoscopes. We've got radiologists that, want to be able to bill, and our POCUS studies are different than theirs. They're very focused. Gets into some of the comments on the med school and integrating this into medical school. Do you have any thoughts or broader comments on the politics and that sort of diffusion of new technologies, the political realm part of that kind of matrix?
For sure. That's an excellent question. Thank you. But there's so many layers to it, right? One of the questions we did ask in the interviews was support from regional imaging specialists, if they had any pushback or if they had support. And delightedly, in almost all instances, people were conveying abject support from the regional specialist who recognized the challenge of doing, trying to care for pregnancies in a very small remote community and the difficulty of that. And so being very available for them, able to help interpret scans, etc. So very, very positive. A couple of instances of a little bit of pushback, a little bit of concern about training, etc. to be expected. The larger political issues that we have to deal with are in training. So we had a lot of discussion about training that I can't go into, but because of lack of time, but the notion of people not having adequate training and feeling the need for a community of practice, feeling the need for CQI. We talked a lot about formal infrastructures. Now the RCCBC is working on a lot of these things, but again, the structures in place to address these political concerns are new and innovative. And so the diffusion is going to take a while, but people are very aware of this and working at it. But I think the biggest one is around CQI and education. Those have to be addressed without a doubt.
Yeah, it's interesting, and it's interesting to consider that there may be differences rurally and urban with the politics, because I can tell you the politics in an urban center is sometimes challenging with these types of innovations, when the argument is it's so available, why do you need to do it? You can just get us to do things. So very interesting. Fantastic work, Jude. Congratulations on that. And we're going to toggle to our next presenter, which is still in the theme of POCUS, and that's Nicole Didiak and Kevin Fairbairn, talking about building point of care ultrasound capacity. And my apologies if I'm mispronouncing names. I'm certainly the victim of my name being mispronounced a lot, so I'm doing my best with those guys.
No, that was perfect. Thank you, Riyadh. Awesome. Well, thank you so much for having us. My name's Kevin. I work primarily as an emergency physician, and we're representing the educational arm of POCUS at this point in time. And yeah, we're very excited to be here. Tracy DeLu, thanks for having us. And we'll go over some of the things that we've been doing over the last few years. And I'm with Nicole here. Hi, Nicole. Do you have the slides, or do you want me to put those up?
Oh, whatever you prefer. Happy to share.
Yeah, you can share, and we'll just go through.
Julian, are you looking for Stefan?
Oh, I'm just going to bring everything up here.
So it's really nice to see our ultrasound family here. Jude, Tracy, thanks for the updates. We're very excited to see what's coming out of those two projects. And as I'll get into with what we're targeting, we're very excited to see how things are going and really pride ourselves on being flexible and providing ultrasound education, because that's one of the keys here. As you can see, there's a lot of change, there's a lot of movement happening within POCUS specifically in technology, and the adaptability of education is going to play a key role in that, and specifically for the rural settings. So what we're looking at is we're looking at a research project that we did with UBC CPD and the hands-on ultrasound education program, or HOUSE as it's known, with rural UBC CPD.
Sorry, Kevin, can I hop in for 1 sec?
Yeah.
Oh, I was just gonna, I am sharing. I just wanted to make sure that everybody could see the slides, and I think I just need Tracy to maybe hop in and let me know which view would be best.
Yeah, you're on presenter view right now, guys. So I don't know if you want to toggle to just slide view.
Yeah. And is that a toggle on Zoom?
It's at the bottom towards the right of your screen, the little mini. Yeah, that's the one.
Gotcha. Let's see if I can get this going here.
There you go. Yeah, looks good.
Thank you so much. Okay, sorry, Kevin, as you were.
Off we go. Here we go. POCUS, rural emergency departments, and education. Next slide. So I'm calling from the unceded territory of the Kootenai people in the Kootenays, Nelson, BC. And I'll pass over quickly to Nicole. Nicole?
Thanks, Kevin. So I'm very grateful to be joining from the traditional and unceded territory of the Coast Salish peoples, as the Squamish, Musqueam, and the Tsleil-Waututh.
Okay, so we're doing a brief presentation on the House course. The House course was initiated in 2015 by the inspirational Dr. Tandy Wilkinson. Very thankful for her guidance in terms of setting this up. We operate in 3 primary arms: emergency medicine, obstetrics, and internal medicine. And what we're talking about today is what we've been doing over the last 4 to 5 years, specifically with our emergency medicine rural education program. Next slide. So as I think most people here are aware, there's no 2 communities, rural communities alike in British Columbia. There's a lot of diversity and a lot of uniqueness there. And so one of the things that we strive to with the House program is offer customizable, locally delivered courses. And that's what sets us apart from some of the other POCUS educational programs that exist out there, is we really try to focus specifically on what each community needs and how they're different and how we can sort of maximize their educational experience. Next slide. What we focus on for outcomes, skill and confidence use in the clinical setting, and of course, increasing uptake in POCUS use in clinical practice. That's one of our main focuses, and then focusing on supporting clinicians as they move forward into other learning opportunities. In terms of long-term outcomes, certainly improving patient care is the goal that we all strive for, as well as longitudinal learning opportunities and contributing to the literature when possible. Next slide. For each course, typically we have a standard pre-course needs assessment followed by post-course evaluation and a 1-month reflective exercise after the course. So fairly standard assessment in terms of how we're gathering our data. Next slide. What we're talking about here today is in 2018-2019, we did a comprehensive qualitative evaluation of what our program has been doing, essentially to look at whether or not we're achieving our program outcomes, specifically for POCUS use and confidence. So with that, I'll pass over to Nicole just to go over the nuts and bolts of the actual research and our results to see what we found. Thank you.
Thanks, Kevin. So as Kevin alluded to, in 2018-2019, we did embark on a more in-depth program evaluation. And what we wanted to know is the House course achieving desired program outcomes such as increased POCUS use and confidence. So what we looked at was an evaluation framework that was actually developed by a consultant, an evaluation specialist. And the House program team focused on identifying key inputs, outputs, and outcomes of the program via a logic model that we were walked through with the evaluation specialist. We conducted 52 semi-structured interviews, which were done over the phone. Participants were invited via email and their anonymity was guaranteed. And the interviews were recorded and transcribed to allow us to analyze the data. The interviewees consisted of various groups, various key audiences. So we had past course participants. We also had key provincial stakeholders, and we had specialist physicians, course instructors, program staff. We really wanted to gather a variety of different perspectives and try to understand the experiences that people were having with our program. The transcripts were first reviewed. They were manually coded by a research assistant, and a code book was developed, which is pretty standard practice for qualitative research. The final coding of the transcripts was then completed using in vivo. So generally, the results supported a significant increase in self-confidence. Increased POCUS use after completion of the course was reported, and positive experiences were reported with the House program overall. What we especially loved about this process of embarking on a deeper dive was that we got some very rich data in the form of quotes and stories. So this one course participant quote is a good example. "I have much more confidence using the point of care ultrasound in practice. Previously, I would look at it sitting around and think, it would be nice to know how to use that right about now. Now I confidently wheel it over and start scanning." So we really enjoyed being able to collect some qualitative data in that fashion. The challenges and opportunities identified. So it's really interesting to be a part of the Zoom room today and to hear some of the themes echoed in our program evaluation as well. So the idea that focused knowledge and skills are best acquired and maintained by ongoing learning, that came up in our program evaluation. And also the idea that geographic and technical barriers demand continued innovation and quality improvement. And again, some of the other folks in this room have been very instrumental in working with us as a program team to try to come up with solutions so that people can develop and sustain their skills in an ongoing way within British Columbia. So in conclusion, some limitations: interviewees may not have participated in a house course recently. So we did kind of dig around. The house course has, the house EM course has been run since 2015. And so there may have been a bit of time in between when a participant took the course and when they were actually reflecting on their experiences with the course. And then also evaluation data from the program did not enable us to demonstrate improved patient outcomes, which is of course, you know, the holy grail. We'd all like to measure that if possible. However, this program evaluation specifically did not allow us to measure that. And that is, of course, the overall goal of the house course. Just wanted to share our findings were published in this Canadian Journal of Rural Medicine. And so if anybody's interested in taking a closer look at our methods or our results, the link to the article is provided. And quickly, just a mention of our partners, the Joint Standing Committee on Rural Issues, which provided seed funding and ongoing development funding for the house course, and then our friends at our CCBC, of course. Thank you very much. We're happy to take questions if we have time. Just stop sharing.
Great presentation, and thanks. There's a question on the data that's needed to demonstrate improved outcomes, and that was actually something that came to my mind too. You know, it's funny that the bar is so high. I mean, we never showed improved outcomes when the stethoscope came along, and yet there seems to be this expectation that we're going to have patient improvement rigorously demonstrated. Any thoughts on that, and specifically the data you might need, or you know, maybe specific areas you could target that you could show a change in outcome or a change in practice pattern?
I personally,
yeah, happy to have you answer. Okay. I don't know, which is why I refer to it as the Holy Grail. I actually feel as though, and I don't want to put Dr. Crittleton on the spot, but I feel like it really comes down to working with professional qualitative and quantitative researchers, in my opinion, and making sure that, you know, from our perspective as a program, that we're investing the time and energy to understand research methods and getting things like, you know, our data very clearly defined, our performance measures lined up. There is some work internally at UBC CPD, the Continuing Professional Development Department where I work. A lot of work actually around how can we better understand the impact that our programming is having on patients, but we're not quite there yet.
Yeah, the only thing I have to add is that unfortunately I do not have a good answer for that yet at this point in time, just only that having this realization and taking this opportunity to change what we're evaluating and develop better questions moving forward, and a way to capture it, the data, so we can analyze it. Definitely looking forward to doing it and figuring out a solution to this, because that is going to be very, very helpful moving forward. I mean, there's a lot pointing towards that it does improve, but we actually need to quantify it. So That's the goal. I haven't figured out a solution yet, but we're working on it.
Well, and the Holy Grail term is a good one. I do feel like there's a bit of a double standard out there, but it's, you know, there's a comment in the chat that some of Jude's work actually will hopefully show patient level outcomes. And so, you know, there's multiple streams of research in this area. I'm going to throw you one last question just quickly, guys, because we're just right up on time. And that is, there was a question on how folks might compare their experience with online POCUS education versus in person, and presumably you can reach more students online. Has there been work done on that, on virtual sims and maybe comparative work, or is that somewhere you might go down the road? Oh, sorry, Kevin, you're mute.
Yeah, I'm good now. Excellent question. From the research that I've been looking at, there seems to be a preference and slightly improved learning in regards to in-person courses. Mostly it's been proof of concept in regards to virtual courses and virtual teaching. Our program, of course, used the opportunity of the pandemic to roll out a virtual course as well, which was successful, but is just behind in regards to in-person learning. So there's a lot of possibility there, especially for rural areas. We'll be able to run courses for places that are hard to reach and in difficult weather, winter, right? We typically go during a downturn during this point in time. So there will be opportunity there and we will have more access and availability. It's just about bringing that level of education up to the in-person courses. It'll be challenging, but we'll get close.
Thanks so much. And great work, all three of the presenters on the POCUS track, I guess I'll call it. Just before our stretch break, we're going to toggle back to Jude Corlison, and Jude will be joined for this presentation by Anna DeWall, talking about something that is extremely timely, as all of you know, and that is responding to climate change and ecosystem disruption in BC. Jude and Anna?
Yep, we're here.
Okay, got you there.
So we are not on quite yet though, right?
You are up now.
Oh.
So yeah, you can go ahead, and if you want to share a screen, you can do that, and yeah,
Yes, I do,
we'll be
and
up with you, and then we'll be on our stretch break after that. Sorry.
Got it. Okay, I will be a little bit more adept at trying to share the screen than the last one. Okay, here we go.
You're such a good speaker. I didn't know you wanted to share the screen. It was it was very nice. Anyway, thanks.
Oh, I'm really sorry about that. Okay, here we go. So what we're going to be talking about is presenting the more the methodology and approach from two funded studies, both looking at rural community resilience, but one from a community perspective and another from a healthcare provider perspective. And I'm delighted to say that we've got a few members of our community panel on with, so I would be delighted if they wanted to jump in and add anything as we're going along. Before I get any further, I am still on the unceded territory of the Tsawat Coast Salish Nation, also known as Salt Spring Island, which on where I live and work, and I still have no conflicts of interest to declare. So the project that I'm going to be talking about before I hand it over to Anna is a project that's been funded by the Spore Support Unit. So building on some earlier work that we did around rural community response to COVID-19. So we were funded for this project last spring when we thought we were going to be focusing primarily on the public health emergency of the day, which was COVID-19. But the events of the last several months, of course, including a heat dome, wildfires, flooding, have really expanded our focus and also, I think, heightened the relevance of what we're doing in ways that clearly we wouldn't have wished for. However, these events have also reinforced to us, the project team, I think that the original motivation behind the work, which was to investigate and document the myriad of ways in which rural communities demonstrate resilience, through the lived experience of people, is incredibly important. So the goal of the work is to look at the contextual factors and activities that are associated with community resilience in BC. And by resilience, by the way, we just mean the community's ability to bounce back. We want to better understand resilience so we can contribute to building, obviously, more resilient communities. And we're doing this through survey research methodology that I'm going to talk a little bit more about. So just as context, again, in March 2020, I think it was, the Center for Rural Health Research Rural Citizen Advisory Committee, who guide the work we do, identified a gap in knowledge around the experience of rural BC's communities during the pandemic. They were more interested in how other communities are responding at a social level to the constraints that we were under more than a year ago. So we launched a survey. We received more than 550 responses from a great representation of communities across the province. And we heard lots of stories about adaptation and resilience, which was great. So the BC Support Unit expressed interest in building on the preliminary research we did, which was done through open recruitment. We didn't look for representative sampling. We didn't compare to urban. We just were doing more of a scoping review of what was going on. But they wanted to know more longitudinally how BC communities were responding. So as we began the community consultations to develop the current project, we recognized kind of a dust statement, I think, that communities are not just responding to COVID-19, but a whole bunch of other disruptions that we wanted to capture. So our partners include front and center our community participant group. So we've got 11 people from rural communities across the province. And by the way, I'm just going to say, this is a stock image from Zoom. I did not use our participant screenshot because I didn't ask them and I wanted to make sure that I had their permission. So I just used a stock image, but it represents this wonderful group of folks we have from across the province who are putting input into how we develop. It's not input, they're co-designing and directing the work. We're partnering with the BC Rural Health Network, delighted to partner with Ed and Ninke and the group. Also the Rural Health Services Research Network of BC and UBCM with funding from the BC Support Unit. So the couple of things I want to say about our community partners is that we were very focused on recruiting to the community panel that is co-creating this work with us to prioritize diversity. So diversity of membership, not only geographically from across the province, but also demographically as well. There's many challenges, as you all know, about getting folks to participate and co-lead things around availability for unpaid work and others that might feel challenged about participating in social groups that may differ from their own, etc. But we really wanted to maintain diversity of participation as a key values proposition. So we sent out posters to communities all across BC, but we targeted different places like coffee shops and food banks and rec centers and social kind of community centers, which is a little bit different than maybe how we would recruit for other groups. We also contacted rural colleges about how to work with them to promote the opportunity to students, and then sent out information to all the RSA communities. And we've really actualized our work together through the collaboration of the Citizen Advisory Panel. We meet every 2 weeks for very robust meetings. We pushed it from meeting for an hour to an hour and a half and said at one point, well, we have to really have a time limit here because we could actually go on talking for more than 2 hours, I'm sure. We also try and communicate outside of meetings through Microsoft Teams and stuff. And this is all to say that the important take home here is that we're really facilitating community partners guiding the goal setting, the priorities, and we take direction directly from the panels on survey development, and we will on knowledge and translation. So something about the survey approach is that what we did this time, and I'm super stoked about this, is that we found an agency that we have contracted to give us a representative sample of rural BC. So they are actually mailing out the surveys to this representative sample of 3,072 addresses across from BC, which is really great if we get a good response rate where we can actually maybe make some inferences to the rest of rural BC about their response to response to disruptions in their community. The other thing we're doing that we didn't do before that I alluded to is we're also doing a representative sample to urban census metropolitan areas. This way we can actually start digging down a little bit how rural response to all these disruptions might differ from urban. And it's also to address many questions I had about our first survey, which was, well, this is really interesting. How does it differ from urban? To which I just kind of shrug my shoulders and say, I don't know, urban scares me a bit. So we're doing this comparison, which we're pretty happy about. What I'm just going to quickly go through that based on the literature and on the direction of our citizen panel, we've derived 8 bucket topics. I call them bucket lists for topics that are related in the literature and based on the panel direction to resilience. And these areas, 8 areas of focus, are framing the sections of the survey. We're asking respondents to speak to these issues based on their personal experience, but based on also reflections in their community. So the issue of affordable housing at large in their community, for example, or emergency planning or trust and leadership. So the survey is open December 1st. So in a couple of days, we're really stoked to get it going. It's going to be open for the month. We've already had people who are aware that we're doing the survey ask if they can fill it out. So because I'm really determined to make sure we can try for a representative sample, I need to know what the baseline is and who we're sending it out to. So we're only doing the representative sampling frame in December, but we've decided a little bit on urging of the panel as well to open the survey wide open in January, and we can compare the 2 cohorts or just have more data. So that's a little bit of extra work, but we're really stoked to do it. We're going to be doing analysis and reporting back by the end of March. For phase 2, we're interested in developing actually a metric based on what we found in the survey to measure community resilience. As a positive way to give to communities to say, okay, so how do you score? And these are some areas, if you don't score well, that you might want to look at. For example, emergency response in your community. And just having gone through floods on Salt Spring, I definitely know that's something we need to work on. So to be helpful and supportive of people moving forward. That's about it for the citizen patient level. I'm going to turn it over to Anna, and I think we'll take any questions at the end if that's okay. So Anna, over to you. Are you going to share slides, or do you want me to stop sharing or keep sharing?
I can just let you know when to switch through them. That's great, Jude.
Okay.
Thank you. Wonderful. So thanks so much, Jude, for that overview of your project. My name is Anna DeWall. I'm a research coordinator with the Center for Rural Health Research, specifically for the CORIG-funded CEDAR study. Dr. Stefan Grabowski is our principal investigator. He's unfortunately at the JSC meetings currently, so I'll provide a brief overview of where we're at and what we aim to do with the project. Thanks, Jude. Next slide. So the title of our study is Enhancing Rural Community Resiliency to Climate Change and Ecosystem Disruption, building on the lessons learned from the first year of the COVID-19 pandemic to strengthen rural community health and health services. So what we're really aiming to do is to obtain a broad perspective from physician leaders and from community members on key strategies and sort of solutions to build resiliency to the effects of not only future pandemics, but also to climate change or real shocks to the ecosystem or to our communities. This project was funded by the CORIG Phase 2 grant, and in terms of our timeline, we'll be ending in December 2022. Next slide, thanks. So in terms of the timeline, we are still early on, sort of in the phases of data collection currently. Alex Bland is the research assistant helping with the analysis, and she and I started early October. We have so far conducted 8 of the qualitative interviews that we aim to conduct, which I'll discuss further in a moment. But just to give you an idea that the SRPC conference is a key knowledge dissemination piece that we'll be getting to in April. Next slide, please, Jude. So in terms of methodology, Jude really gave a good high-level overview of many of the climate change shocks that BC has been experiencing. If you look at the past 6 months, from the heat dome to the atmospheric river to, these major shocks to the environment, those are going to be increasing in the coming years. And what we're really hoping to obtain is to see sort of strategies that can help communities and physicians be more resilient to those effects. So the methodology we're using is snowball sampling, going through physician leadership. And this isn't to say that physician leadership is the most important piece of community resiliency, but that they do have an important role to play in supporting that. And so we're hoping that through the SRPC and through rural community physicians that we've reached out to, that they'll be able to direct us to community leaders, to key community informants, that'll be able to tell us a bit about leadership, about partnerships, and about sort of strategies in their communities that help them be more resilient to the effects of the pandemic. Hoping to be focusing on both communities that were resilient and to ones that had challenges during the pandemic. The idea being that we can learn from both of them. So aiming to connect with 12 communities across Canada, we've so far identified 8, and again, conducting around 5 to 10 interviews in each of these communities with both physicians and community members. We'll be returning to each of the communities for a community forum after data collection. The idea being that we'll present results from both their community and from across Canada, trying to see if we got it right, see if they have feedback on our results, and sort of to refine our analysis. Next slide, please, Jude. Thanks. So again, these are qualitative interviews. They're semi-structured, focusing on partnerships and on leadership, supporting resiliency. We'll be transcribing those interviews and conducting a thematic analysis in vivo, taking a logic model approach. And just to say that a youth advisory committee and an Indigenous advisory committee are really important pieces in informing our research engagement. That being that climate change is of particular interest to youth in the communities, and that Indigenous engagement is a very important piece of our promoting climate resiliency across Canada. So we're hoping that regular meetings with them will inform both our research engagement and down the line for the analysis. And in terms of a theoretical lens that we're taking, it's really through transformative resilience that we hope to understand some of these findings. So our definition here is the system capacity to transform itself in response to changing conditions and disruptions. Next slide, please, Jude. Thanks. Key outputs from this research, we're hoping to develop an educational toolkit and framework of rural community resilience, which could then be shared with other rural community physicians in terms of how they can transform their practices or implement these strategies to help their communities become more resilient. Part of that will be a pre and post SRPC conference survey that'll be assessing the impact of our workshops, which will run at the SRPC conference, and it'll inform the generalizability of our findings. We do also hope to work with 5 demonstration communities that will sort of be implementing the strategies presented in our toolkit, which we'll do in collaboration with Jude's team, and sort of see if those lessons learned from our study do in fact help them sort of bolster their systems and transform some of the strategies they use in their communities. Next slide, please. This is just to present a brief overview of our proposed workshops for the SRPC conference. So that'll be April 21st to 23rd in Ottawa. We hope to sort of provide an overview of the rural physician-led community strategies that we identified that they used during the COVID-19 pandemic. An important component is also engaging medical students. So sort of promoting a rural community perspective among medical students, and our flex students will be presenting. Also have a rural and Indigenous workshop, a rural youth workshop, and one on inspiring collective behavior change in rural communities responding to climate change and ecosystem disruption. Next slide, please. And in terms of our collaboration with Jude's team, we're hoping to be able to include a couple of our questions on rural physician leadership in their survey. And we'll also be collaborating in creating that educational toolkit, hoping to integrate findings from both of our studies, sort of the survey and the qual interviews, in terms of what could support community resiliency in a broader picture for both physicians and for community leaders that are hoping to enhance their community resiliency to ecosystem disruptors. That's it for me. Thank you so much.
Thanks so much, Jude and Anna. It's hard to imagine a more important topic after all that we've all been through in the last several months in BC. I don't see any questions on the chat, but maybe I'll ask you one question and then we'll move to break. And if there are other questions, we can put them in the chat function. I was really impressed with your sampling strategy. You know, this whole concept of a snowball strategy where the sample grows outwards as you start to engage folks. You know, one question I had, and I think maybe it's more directed towards you, Anna, is the concept of targeting specific communities. How did you pick out of those 12 communities that you want? How do you pick communities? And is there a concern that there, you know, could be distortion or bias based on the communities you pick? I mean, obviously that's inevitably a challenge, right? So I'm not saying that critically, but I'm just asking you how you chose the communities that you worked with. And there is also a question in the chat about what's the company that you're working with to send out the surveys.
No, I can answer the first question. Thank you, Riyad. That's a great question because I think we do want to be careful in terms of which communities we're working with. As I mentioned, this is a pan-Canadian study, and the sort of key ones we've been able to identify have been through our informants at the, through the SRPC conference and our SRPC connections. We're hopeful that we'll, be able to recruit a couple other communities. So I might pose it to the group as well. Happy to share my contact information in the chat. But if there are specific rural community physicians that have demonstrated resilience, we're hoping to recruit a couple of other communities. And I think just to say that in terms of mitigating bias, we're hoping to work with both communities that were resilient, but also learn from the ones that weren't. So I think that there are still key findings and key takeaways that we can bring from sort of communities that, that suffered or communities that really thrived throughout the COVID-19 pandemic.
Thanks. And that last question was just regarding the company. You'd mentioned that you've got a company that's helping you with the surveys.
Yeah, so it's actually IDRS is sending out the invites, but the survey is online. But by the way, what we're doing is we're providing a link to the survey, but we want to make it as accessible as possible. So we're also in the invitation providing both our email address if anybody wants to be mailed a hard copy, but also if anybody wants to do an oral survey over the phone, they can call and someone in our office will actually read them the survey and accept responses.
That's fantastic. I mean, it's that sort of thing that gives you the most representative sample possible. So great work, guys, and great work, all of the presenters in the morning slots. We're right on time. We've got a 5-minute stretch break. So we'll be reconvening here in exactly 5 minutes at 10:30 with Jessica Burt. Okay, well, welcome back, everybody. It's 10:30, and just to orient you, you're in Zoom room B. I hope you're all where you want to be. I'm Riyad Abuleben, and I'm happy to be moderated on behalf of the BC Emergency Medicine Network. And we'll continue on with these great presentations that we've had. So I'll now introduce Jessica Burt, who's going to be speaking to us on resilience to the health impact of climate change in rural BC, comparative policy analysis. Jessica.
Thank you, Riyad. So I'll just share my screen quickly. Can you all see that? Yeah, great. And thank you to BC, RCCBC for having me. It's really nice to be here at a part of this event. And I feel like it's been really interesting to hear all the presentations from this morning. So thank you. I'm joining from the United Kingdom, from Leeds. I'm a final year medical student. And like Riyad said, we'll be presenting on the resilience to health impacts of climate change in BC, rural BC through a comparative policy analysis. So this was undertaken as part of a master's degree in global health back in 2020 and was supervised by Jason Curran at Interior Health. I'd like to take a moment to acknowledge that this research was collected and conducted on the traditional and unceded territories of the First Nations of Ktunaxa, Secwepemc, Okanagan, and Haida. So rural and remote communities have been identified as some of the most vulnerable communities to the health impacts of climate change in Canada due to the interaction of environmental changes, resultant health impacts, and the socio-economical environmental context. This diagram highlights the key environmental changes as being increased extreme weather events, including flooding, landslides, forest fires, and storms, as we've unfortunately seen over the last year, and changes to ecological systems such as water, forest systems, and agricultural land. The resultant health impacts are the insecurity of food and water, exacerbations of chronic diseases and changing infections, increased injury and mortality, and a general decline in mental health and well-being. And with the rural setting, there's specific circumstances which interact with this. Challenges include a reliance on natural resources, the geographical remoteness, limited capacity of healthcare systems to respond, and limited physical and social infrastructure. But there are strengths coming from the sense of community felt, including social capital and social networks, community involvement and participation, and place-based knowledge systems. Resilience frames this in a more positive way and looks at the ability of a community to withstand those negative effects of climate change without resulting in negative impacts on the population and remaining in place, and can be seen as the product of adaptive capacity, persistence, and transformability. BC is noted as a world leader in climate action, as through the provincial requirement for all communities to include greenhouse gas emission reduction targets in their official community plans, OCPs, from Bill 27 in 2008. This provides an opportunity for real place-based community transformation and climate action. So the aim of this research was to analyse the current resilience to the health impacts of climate change in the official community plans from 2010 onwards. And this was to identify areas in policy which foster and inhibit resilience, and to hopefully create a collection of approaches which could then be disseminated and shared. So this was done through comparative policy analysis based on that of Bainham and Stevens from 2014. So a score was given for fact base, goals, policies, implementation, health, and framing, and this was then compared. And a contextual profile was also built, which looked at the 2016 census data, some health authority data, and local election results. And this gave a greater idea of the bigger picture for each community. So we looked at 4 communities in particular, and this was chosen through purposive sampling. So it had to be listed on the RSA list of rural communities, and there had to be an easily accessible OCP updated since 2010. And then contextual profiles were considered to ensure we'd looked at a range of settings. So this isn't representative of all communities in any way, but just a selection. So the communities looked at ranged across the interior and northern health authority regions. So the first was Elkford, which through the demographic profiles was seen as had a younger population, a wealthier community, reliant on carbon intensive industries, and had lower post-secondary education and the highest use of public transport. The second was Spanamtune, determined as a smaller population with an older community, reliant on agriculture and had the lowest employment rate. The third was Williams Lake, which was a larger population centre with a population of over 10,000, high population density and also dependency, and the highest unemployment rate. And the final community was Masset, a small coastal village with a population of less than 800, a large First Nations population, the highest post-secondary educational attainment, and a decade's disparity in gender-based life expectancy. So looking at the OCPs, the first covered the emissions policy areas well and had the highest inclusion of health. There was an extensive energies emission profile, climate change was locally relevant, and there were short-term greenhouse gas reduction targets, clear community adaptation goals, and the health co-benefits of active transport and what impacts of wildfires were discussed. This had been developed with Columbia Basin Trust, and their climate change adaptation strategy and greenhouse gas reduction strategy were both available and online. The second OCP had a good range of greenhouse gas goals and policy areas covered, but there was little explicit inclusion of climate change or health. It focused on the protection of agricultural lands and practices, suggested the development of a community energy plan, and recognised the health co-benefits of active transport as well. The third looked at the specific impacts of climate change to the setting with specific health impacts. Mitigation policies were also included, focusing on infrastructure and areas where external collaboration could be useful. And there was a larger focus on local food production and delivery, and this was linked with food insecurity and improving quality of life. Throughout this, social well-being and ecosystem services were recognised as an important driver for this. And there was a community energy and emissions plan. And the final policy had a strong link throughout between environment, well-being, and health. There was a recognition of key areas of emissions and energy usage, a glossary of climate-related terminology, the identification of community climate change adaptation goals, a focus on local food production again, and a section devoted to individual and community health. This had an infrastructure and asset management plan, a climate change adaptation strategy, and a full implementation guide with cost estimates. And this also had been developed with the Whistler Centre for Sustainability. So looking at the general themes, we can see it's evident that the provincial mandate for greenhouse gas emission reductions has been successful in starting climate action within each community, but this alone doesn't go far to foster resilience. As we can see, plans range from a detailed exploration of impacts of climate change as specific adaptation plans to more broad mitigation plans without any evidence of implementation. Active transport has been clearly recognised and focused on as a health co-benefit of mitigation, but there's minimal evidence of actual shifts away from car-based transport since these policies have been written. Thirdly, local and sustainable food production has been identified as well as an adaptive mechanism, and this covers social inequalities and quality of life in sustainable transformation. The inclusion of health varied across the policies, with the direct health impacts of extreme weather events, including wildfires and flooding, most comprehensively covered. Yet the wider recognition of the environmental drivers of health and well-being were more prevalent in communities with larger Indigenous populations, highlighting the importance of recognising and understanding Indigenous ways of knowing and being within community transformation, and utilising these place-based knowledge systems which are specific to the socio-cultural contexts. Only those communities which had partnered with external organisations had clear adaptation goals and thus greater adaptive capacity. And this could be due to being able to identify further action areas and foster systems which can ensure that these are followed up. So overall, the implementation does remain to be seen, but it's clear that local ownership is important in continuing this momentum and ensuring that these plans are put into policy. A few well-implemented policies leading to realised change can contribute far more to the resilience than a broader scope with little action. So in conclusion, we can see that there are a variety of approaches taken, and this in itself influences resilience. Whilst health has been discussed, the link between health systems in community planning comes across as limited. Those factors which facilitate adaptation foster resilience, which better protects health and well-being in a general sense. And finally, it's evident that engaging with external partners and participating in a collaborative, community-owned process is key to realising long-term resilience to the health impacts of climate change. So thank you to Interior Health for facilitating this research, and to all the collaborators from Eltford, Ballantrae, Williams Lake and Masset for providing access to the resources. My email address is there if you have any further questions or would like to hear more about the study. Thank you.
Fantastic, Jessica, thanks so much. And congratulations on actually being exactly on time despite being 8 time zones away from us. Really important topic and really interesting. Just a reminder again to everyone that we're using the Zoom chat feature for questions and comments. So please put anything there. There isn't anything up in the chat right now, Jessica, so maybe I'll start with one question for you. I was really intrigued with your finding about the difference in communities that had a higher proportion of Indigenous citizens. And my question is, was that reflective of the effect of the Indigenous population alone, or was that a reflection of the community as a whole was in fact different as a result of that?
I think that's a really...
You understand what I'm getting at there? I'm just wondering, you know, does the presence of an Indigenous community actually help to improve the resilience of the community at large, even outside the Indigenous population?
I think obviously this was looked at through policy analysis, and I haven't spent time in these communities to give you a full answer to that. But from what it came across, it was more that having an Indigenous proportion of the population engaged as part of the community influenced the approach taken. So it was Williams Lake and Masset who both looked at the environmental drivers of health and took a more general look at well-being in relation to the place. And so I think it's more being active participants and a part of that community rather than just statistically having a larger proportion, if that makes sense.
Mm-hmm. That's a fascinating finding. There's one comment and question in the chat, just making the point that climate change is intrinsically connected to health outcomes, and asking, do you feel that the provincial government is actually fully aware of that and the resulting extra cost to the healthcare system that would arise from that?
Again, I'm not sure I'm the best person to answer that question, but from the research and reading that I did, there wasn't much understanding of this. It was much from the provincial level and from those policies that were implemented and those mandates. It seems to be much more of a local and thing that's realised from the healthcare systems, but not necessarily from the provincial policies or mandates, no.
It's an interesting state of affairs that we're in, that I think we're all going to become increasingly aware of that connection, even if we're not aware of it yet. In fact, you know, our next presentation links to that as well. It's the issue of human activity on the environment and on our health and well-being. Any other final questions anyone wants to put in the chat? I see one there. How do you think that this we can facilitate the knowledge transfer from healthcare communities to government bodies? I guess speaking to that issue of government's awareness of this problem and the connection to health.
I think that's a really important question, and again a really difficult one to know the straight answer to this, but meetings like this, doing this research, getting those results out there and sharing them and raising our voices and sharing what's going on, I think is a big way in doing so.
Yeah, it's probably multifaceted, isn't it?
Yeah.
Well, we'll leave it there, but we're on the same theme, even with the next presentation. Jessica, thanks so much. And so we're going to switch now to my old friend and colleague, Dr. Margaret McGregor, and she'll be joined with Karen Levin, talking about the human health effects of unconventional natural gas development and a systematic review of that.
Hey, Riyadh. Thank you for chairing this meeting, and thank you, Jessica, for a fabulous presentation. Super interesting. So welcome to this presentation. I'm speaking from the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations down in the big city, Vancouver. Here is a, let me see if I can get this going. Come on. Yeah, here's a picture of our research team. And with us today is Karen Levin, and I should also recognize Ulrika Meyer, both of whom hail from Dawson Creek, which is one of the big centers where there's a lot of UNGD, or unconventional natural gas development, otherwise known as fracking, taking place. So what is UNGD? UNGD is an industrial process that became popular in the mid-2000s to extract underground natural gas deposits from shale or tight rock. So that's as opposed to porous rock, which is the conventional technique to remove natural gas. So UNGD first involves clearing about 3 to 5 acres of land and transporting material to the site. This is known as the pad preparation phase. Then a shaft is drilled vertically 3 to 4 kilometers down into the ground. And this is a sort of depiction of that. So it goes past the fresh and saline water aquifers, and then it gets drilled horizontally for another 2 to 3 kilometers. Typically lasts up to 1 to 2 months to do this portion. And then once drilling is complete, a slurry of 11 to 19 million liters of water mixed with sand and chemical additives is injected along the well shaft under enough high pressure so as to create microfractures of the shale or tight rock, thereby freeing trapped gas. And this is called the stimulation phase. This is where fracking gets its name and typically lasts about 1 to 2 weeks. So it's estimated that until this point, over 1,000 trucks per well are required. And then after the stimulation phase ends, production begins. So this slide shows only one well on top of the pad, but in reality, a single pad houses multiple wells that snake out in all different directions. And Canada is the 6th largest producer of natural gas, with over 85% of our gas derived from this technique. So BC is the 2nd largest producer of frack gas after Alberta in Canada, and this occurs mainly, well, only in the northeastern part of the province among highly productive farming communities in the North and South Peace River and on the traditional territory of the Treaty 8 First Nation. So the map on the left shows the location of UNGD wells in northeastern BC, and the map on the right shows the territory of the Treaty 8 First Nations. You can see it's partly in BC, partly in Alberta, and partly in the Yukon. So what are the specific concerns about these chemicals? This is a list of some of them known to be related to UNGD that environmental researchers have actually detected in higher levels in the air, water, and soil close to UNGD activities. And there's actually a large body of peer-reviewed literature that describes potential harms of these chemicals that include things like carcinogenicity, mutagenicity, endocrine disruption, oxidative stress, and inflammatory effects on human cells. And then this is just a little table summarizing how these substances can escape into the environment through various means, including things like frac fluid spills and leaks from disruption of the pipe integrity, pollution from truck traffic, pollution from compressor station engines, venting and flaring of gas, and aerosolization of frac fluid and wastewater into the ambient air. And here's a photo of gas flaring. It's a common sight at night when traveling in communities where UNGD is taking place, and a source of polyaromatic hydrocarbons and air pollution. Here's the photo of a wastewater pond of frac fluid, and you can see how the pond is lined with a black plastic liner that can deteriorate over time, allowing fluid leaks into the aquifer, and also how the chemicals in the fluid have the potential to aerosolize into the surrounding air. So our research objective was to systematically review the epidemiologic and biomonitoring peer-reviewed literature, assessing the effect of UNGD on human health, with a particular focus on identifying Canadian studies and studies investigating impacts in Indigenous and racialized populations. We included studies published in English or French between January 2000 and July 2021, where health outcomes were plausibly caused by UNGD-related chemicals and which directly measured or estimated exposure through proxy. 2 reviewers independently screened abstract, full text, and extracted the data, and then results were summarized descriptively. We excluded studies that assessed the effects of UNGD on climate change, on seismicity, on air, water, and soil quality, on animal health, on community disruption, economic and social impacts, or where health outcomes were not related to UNGD-related chemical exposures. For example, sexually transmitted infections, noise effects, traffic accidents, etc. So this is a figure that describes our process. And as you can see, out of over 4,000 studies, we identified 36 epidemiology studies and 2 biomonitoring studies that met our inclusion criteria. And these studies were set in 7 different jurisdictions, 6 from various US states and the northeast of British Columbia. So what did we find? Well, first, a majority reported adverse associations with UNGD exposure and health, and a majority described increasing magnitudes of harmful effects with exposure to increasing levels of UNG activity in 1 or more of the analyses, which suggests a linear dose response. Second, 1 or more studies reported greater risk of lower average term birth weight, preterm birth, low birth weight or less than 2,500 grams, small for gestational age or birth weight less than the 10th percentile, fetal death, early infant mortality, congenital heart defects, and neural tube defects. And this is a forest plot that looks at preterm birth, and you can see that most of the effect estimates associated with exposure are greater than 1. Third, 1 or more studies reported greater risk of asthma exacerbations, congestive heart failure exacerbations, hospitalization for myocardial infarction, childhood acute lymphocytic anemia, leukemia, not acute lymphocytic leukemia, and self-reported health symptoms. And here's a forest plot of UNGD activity associated with hospital emergency room visits and admissions for asthma. And again, odds ratios are consistently above 1, and you can see generally a linear dose response curve with increasing levels of exposure. Finally, only 3 Canadian studies were identified, and greater impacts in Indigenous and racialized communities were seen in the few studies that looked at this. So what can we say in summary? Well, first, there's a growing body of research across multiple jurisdictions reporting associations of UNGD and human health harms, with many showing a linear dose response effect. And there is evidence of disproportionately greater impact in Indigenous and racialized populations among the few studies looking at this. Canadian research on the health effects of UNGD is remarkably absent. This evidence of absence of research is concerning given Canada's almost 20-year history of UNGD, the industry's continued expansion, and its location on the territories of many Indigenous communities already disadvantaged by health and economic disparities due to colonization. Now, Canadian policymakers are increasingly aware of the disproportionate burden of environmental degradation borne by Indigenous and racialized groups, with a parliamentary bill actually on the topic of environmental racism having passed second reading in the spring of this year. So our conclusion is that research is now urgently needed to better understand the potential differential exposure and health impacts of UNGD on Indigenous and racialized populations in Canada. And thank you for listening. And thank you for RCC for giving us a research grant to look at this question.
Thanks so much, Margaret and Karen. You can turn screen share off now, and we'll open the floor to any comments or questions. I think that I'm kind of horrified that there's actually an acronym for this. I didn't even realize there was, so that was a learning experience for me. Maybe I'll ask you one thing just while we see if anything else comes in. This is great work, and those forest plots are really compelling. One sort of technical question on the forest plots and one question on the research itself. Are you able to combine those studies into a summary statistic? I noticed that wasn't on your forest plots, and I wonder if that might make the sort of take-home message clearer. And then my strategic question is this something that you might, or maybe you already have, pursue with Cochrane and register as a formal Cochrane review?
Well, the first question about whether we can actually do a quantitative meta-analysis, which I think is what you're suggesting, we looked at quite carefully and realized that because the approaches and the types of studies were so different, it would be impossible to combine to come up with something intelligent. There was just so much heterogeneity of various different approaches. Okay. So the answer to that is no. We did register with Prospero. We haven't registered with Cochrane. So yeah. And we did initially attempt to do a kind of formal bias assessment, but again, that became so complex because of the various ways exposure was approached, outcomes were analyzed, so many different outcomes. And then the different methodologies, like it was split between case control, many retrospective cohort, and then quite a few ecologic. So
Right. Okay. Yeah, and I get that, and that's just a challenge of the literature. I mean, those forest plots certainly paint a compelling picture, you know. So it's really important work, regardless of whether you can combine all of these studies into some summary statistic and meta-analysis. So congratulations again. This is great work. I guess I don't see other questions on the comments. So am I missing one there? No. So maybe I'll leave it for others to pose questions if they have them through the chat feature. And we'll stay very slightly ahead of time here and move on to our next presentation. So thanks again, Margaret and Karen. Great work. So now we're going to hear from Dr. Sean Maurice from UNBC talking about youth perspectives on healthcare careers.
Okay, does that look okay, Riyadh?
Looks great, yeah.
Super. Okay, so thanks so much for the chance to speak here. And I'll start by acknowledging that I'm calling in from the traditional, ancestral, and unceded territories of the Lheidli T'enneh. And I'm a settler here, and our relationship with the Lheidli and the many other First Nations of Northern BC is really important to UNBC and to the Northern Medical Program. These are important stakeholders. I do not have any disclosures. So this project was originally entitled Rural Youth Perspectives on Healthcare Careers. And it was actually established pre-COVID, but we had to adapt it a little bit during COVID. And we also adapted it to be youth perspectives in general, because we realized it was going to be hard to say much about rural specifically if we didn't have some sort of a comparison. So we know that health professionals raised in rural communities are more likely than their urban counterparts to choose a rural practice. But the literature tells us that there are barriers that rural youth face in pursuing healthcare career training, that it's farther from home, and the culture is different, and a variety of other things. But we wanted to better understand that. So we designed the study to help us understand youth perspectives on healthcare careers across BC and educational barriers these youth perceive. And my background is as the lead for the Healthcare Traveling Roadshow, which is an initiative that started at UNBC and is now a provincial initiative. We go out to small towns and try and sell rural practice to our healthcare trainees from an interprofessional group of studies. And we go to high schools and try and get the grade 10 students mostly there to think about healthcare careers. And one of the assumptions we've made over the years is that they probably don't know about the full spectrum of possible careers. So this study was designed to help us understand youth perspectives on healthcare careers and barriers that the youth perceive, as I've just said. And we did this in an interprofessional context and across the diverse demographics of BC, or at least as well as we could. So we developed a Qualtrics survey and asked youth about their awareness of healthcare careers, their sources of information about career opportunities, their own levels of interest in pursuing a career in healthcare, and potential barriers to education and training. And we used the Statistics Canada definition of small population center, under 30,000, medium 30 to 100,000, and large over 100,000. And we actually had 4 small population centers, but 2 backed out for various reasons. So we ended up with Vail Mountain Invermere. Our medium population center was Prince George, and our large population center was Victoria. And our sample sizes were pretty small. You can see there between 20 and 26. There were probably over 1,000 youth across these different communities who were invited to participate, but that's how many filled out the survey. So when we asked them if they'd heard of different careers before, and we have to acknowledge that we gave them this list of careers, and they just did the checky box thing, the rates were pretty high, and they weren't significantly different across our populations. And as I mentioned, one of the things we do in the roadshow is to try to introduce that medicine or healthcare is more than just doctors and nurses, and that there's a whole bunch of different programs. Training looks different, and the stories people tell from those professions are different. So certainly there's some awareness here in some of the professions on the right side of the screen, but my initial read of this is like, oh, well, awareness is reasonably good. But then when we asked them to expand a little bit more about what could help, they said things like, I know very little about healthcare careers because we receive little to no exposure at school or in the community. So that tells a bit of a different story, I think. And then one of the suggestions was that we should introduce the healthcare careers and give lessons on what they do and how to pursue them. It's difficult to know this information, and it would make it easier if we were taught about them. So that kind of supports some of the work we're doing with the Roadshow, and says despite a little bit of awareness about a variety of careers, they don't feel like they know too much. We asked where they've heard or read the most about healthcare careers, and you can see here across our different populations and for total, family, friends, social media, TV, movies, and books are all pretty high. Teachers are pretty high. The highlighted in green are the ones that were the highest for that population, and then in orange are the lowest. And for some reason, guidance counselors are substantially lower. We don't really know why this is. We don't know if it's because they're not seeing guidance counselors. In a lot of small towns, teachers also do the guidance counseling. So I'm not sure if they're seeing teachers as the guidance counselor role or not. Some of the barriers identified across all populations. They talked about the cost of post-secondary education as the most commonly cited barrier to pursuing a healthcare career. And some of our participants, presumably from rural communities, especially, we often hear in rural communities that it's hard to get students to even finish high school because they can go and work on the oil rigs and make $80,000 a year. I guess that's my connection to the previous talk. You know, when boys when they're 16 can do that. And so there were different comments about the cost and also the cost benefit, like so many years of studying, such hard work, so much debt, and what do you get in the end? Like, can you even earn enough money as a healthcare provider? That came up a couple of times. In terms of barriers specific to our rural population, students from small population centers were more likely to indicate that they didn't feel smart enough or didn't feel they or their peers would be qualified for a career in healthcare. And so that ties in with some of the previous published work that says that there are greater barriers for our rural youth. So even though awareness seemed to be similar in this population, all the other demographics seem to be similar across these populations, our rural youth still felt that there were greater barriers and had less confidence that they could pursue healthcare careers. So that I think is a justification for doing more outreach to rural youth to help overcome those barriers so that we can get more of them into training where they're underrepresented. We asked a few questions about the COVID-19 pandemic, and we did have youth saying that, we had a few saying it increased my interest in healthcare. We had a few saying it decreased my interest. On average, it didn't really change. And there was a bit of gratitude for the healthcare workers that came out, which was nice. But overall, it didn't affect their career decision-making. So I think I'm talking too fast. This is the conclusion. Despite reasonable awareness of and interest in healthcare careers, youth in this study want more information to be given to them during high school. And youth in this study view costs of post-secondary education to be a significant barrier. Youth from small population centers are less likely to feel a healthcare career is achievable for them. And so I have to acknowledge we have limitations. Of course, this study was conducted during a global pandemic, which may have affected uptake, and we used a convenience sample, and the study was subject to selection bias because we relied on youth who chose to participate. That is, youth who were organized enough to bring the consent and assent form home and bring it back to the school so that they could participate in the online survey. So big thanks to Kurt and Shagun at the IMP and SMP, other small sites of the medical program respectively. And big thanks to the school administration, teachers, counselors who helped administer this study. They were the ones who had to collect the forms and mail them back to us and make sure that the youth could get on the computer to do the survey. And the Center for Health Education Scholarship for our funding. Thanks for your attention.
Fantastic, Sean. Thanks so much. There's already a comment in the chat from Tracy in Haida Gwaii saying, please have a roadshow up there. I'm sure, Tracy, you're not going to have trouble convincing anybody to come visit beautiful Haida Gwaii. So again, anybody with questions or comments, please go ahead and put them in the chat.
And just to comment on visiting Haida Gwaii, we do sort of have a rotation, and we've been to all the towns in northern BC now. We were in Haida Gwaii. I thought we saw you, Tracy, in 2016. You're sort of next on our rotation, so maybe spring of 2023.
There's a question from John Grogan, who's one of our patient partners actually in the EM network, asking whether you've made use of social media in your work.
Well, a little. So we have a Facebook page, and we tweet when we're on the roadshow, and we involve our funding partners and conventional media when we're in town. Sometimes we get to speak on the radio, or we end up in the local paper. We also have a virtual roadshow. I assume you're asking about the roadshow itself. We have a virtual roadshow, which has, because we can't be in Haida Gwaii every year, for example, we're talking about a 7-year rotation right now with the upset of the pandemic. We do have a virtual roadshow that has career snapshot videos of 14 different careers so far, and we're trying to add to that each time we do the roadshow. So we usually bring along a filming student who will choose a few of the careers that we haven't represented before. Yeah, sorry, I'm being distracted, Tracy. Yes, we are working with Rural E-Mentoring as well to try and advertise that initiative while we, it's sort of under the same umbrella of just trying to provide opportunities, right? We have a newsletter that we send out to our northern schools.
Maybe I'll just finish this session with one other question for you, Sean, and that's, you know, I find it particularly interesting that the comparative evaluation that you're able to do, you know, the fact that you went to small, medium, and larger communities, and you made the comment that there's some things you're finding that are disproportionately represented in smaller communities. Is there a way to quantify the magnitude of that difference, or is that sort of a thematic finding that you just are reporting on?
Well, I mean, we can quantify how many people said that, but if that's a qualitative component where we're just asking them to identify barriers, and then we're coding and we're counting. So you can count how many times the codes came up, but our sample size is small. So right. I think it's, if you were trying to come at it from a robust statistics angle, reviewers wouldn't be happy with that. So I think we're better just to describe that.
And I wasn't meaning to suggest that qualitative methods are any less robust. In fact, a lot of people would argue they're more robust, right? I just wasn't clear whether you were asking questions that you could translate into you know, a proportional likelihoods of folks from various communities feeling certain ways, or whether this was more qualitatively based on your thematic sort of analysis of responses.
Yeah, it's more qualitative, but we could give numbers to it, which just to help describe.
We do have time for one last quick question, and that's what's the timing of the response to the impact of COVID on participants' career decision? Is there a relationship at all with that?
Yeah, so by the time we got everything sorted, the survey was open between December of 2020 and April of 2021. So it was somewhat late, or maybe in the middle of the pandemic. It wasn't in the early days. Yeah, thanks, David.
Yeah, it'd be interesting to see the effects of that, both positive and negative, on healthcare, both our current providers and future providers. I mean, there's going to be a range of responses to COVID, isn't there? Fantastic work. Congratulations on this and great presentation.
Thanks so much, Riyad.
So we'll move on now to Dr. Andrea Gingrich from UNBC, talking about juggling the different hats we wear. I think that's something familiar to many of us on the Zoom today.
Sure, just give me a second to get my screen set up here.
That looks good.
Okay, and you can see that? Wonderful. So thank you for the opportunity to present this work on behalf of our research team. I'm presenting from Prince George on the unceded territory of the Clayton. And I also want to thank UBC and CHESS for a distributed medical education grant that funded this project. Professional boundaries. They're fascinating because they're foundational to what it is to be a professional. They're judged in terms of legalities and morals and ethics, and yet they're variable because they're context bound, they're socially constructed, they're negotiated, and this makes it a bit contentious, and that's exactly the sort of thing that I like to study. And the contentiousness is magnified by the successes of one of our social accountability efforts. And the one I'm referring to is addressing medically underserviced communities by recruiting people from those communities with the expectation that they'll return to that community and provide culturally appropriate care and practice in that community. And in recent related work, we described how this exact thing creates a paradox in which providers such as physiotherapists must navigate while they're practicing in rural, northern, and remote communities, because they must treat friends, family, and acquaintances for a variety of reasons, while feeling that their professional organizations expect them to avoid such overlapping roles. Now, in this study, we wanted to learn more about setting and maintaining boundaries within such overlapping relationships. And we had interviews with 22 physicians in BC who were or had practiced in rural, northern, and remote communities. And we especially targeted our recruitment to insiders, so those who had returned to their hometown to practice or who had lived and practiced in a community for decades. And that's because we really wanted to talk to people who were embedded in communities and most likely to have a lot of experience navigating overlapping relationships. And our study drew on constructivist grounded theory methodology, which is a qualitative research method. And I'm happy to go into more detail on that in the question and answer period if you're interested. So again, we heard that overlapping relationships and dual roles were the norm, and they were unavoidable, and they created paradoxes. Here's a quote: "The college has the rule, you don't be friends with anybody, but in a small town, that would come across as being a very strange person for one thing, and you become a strange person after a while if you have absolutely no friends that you can talk to." In the context of ubiquitous overlapping roles, boundaries were described as the edge, where, for example, my license becomes at risk, that's where my boundary needs to be. And I draw a line and be firm and say, this is what I can do, and this is the boundaries. So to be able to set a firm line, boundaries were described as rules. They were thought of ahead of time and then needed to be maintained and defended. And that made exceptions problematic and considered to be a violation. Examples that were commonly given include things like giving out a cell phone number or listing a home phone number, treating friends and family for particular things under certain conditions, but then not under other conditions. But navigating overlapping relationships was more than just setting and maintaining boundaries. And what we heard repeatedly was a hat metaphor, such as juggling the many hats that we wear. And I'll show you an example here where it was described in terms of navigating incidental encounters with a patient who wasn't a friend. So imagine wearing two hats, and at this moment in time in the clinic, I'm wearing that doctor hat. And when I step out of this clinic room, I'm still wearing the doctor hat, but it's in my back pocket. And I'll just kind of push the doctor hat further down in my pocket, but keeping in mind that I've always got that doctor hat in my pocket and I can never be away from it. The hats are metaphorical, of course, but yeah, as we analyze the stories that were shared with us, we saw how it was being used to describe how navigating overlapping relationships involved this navigating multiple roles. And that was done by signaling, separating, switching, and suspending certain roles in order to respect personal and professional obligations. And I'll give you examples of each of these. So there's various techniques used to signal which role they were in and what to tell other people which one was appropriate for that particular interaction. So a common example, when I'm working with someone, as a colleague, we use first names. We're not formal. And when I'm at their doctor's office, I call my doctor by their doctor names. I think using those formal titles helps maintain boundaries when you're in those kinds of situations. So using first names during social encounters and when working with colleagues without others present, and then using formal titles when seeing a colleague as your physician or your child's physician, or when referring to a colleague in front of others, especially patients, could signal which role that person was in and how you were communicating with them. In this example, we see more explicit signaling along with separating the roles based on location. So especially with my family, I would go like, so I'm at home now. I don't have my doctor brain on. I have my sister brain on. So let's wait until I'm at the clinic and I have your file and I can think about this with my doctor brain. Now is not the time. So separating roles was more about organizing roles into the right time and place. It often meant delaying a conversation until the right context. Switching roles was more about changing the role during an interaction or alternating between perhaps separated roles. So many of the examples was where they needed to be in a doctor role for a friend or a family member. So here's the quote: "As soon as we get into the clinic here, because I have to put my doctor hat on and I have to stop thinking as a friend. And so I tell them, I'm now Dr. X. I have to think about it and treat you the way I would any other patient. So we can see this explicit conversation and marking of which role that they were using in the interaction. They often talked about setting aside their other personal roles or compartmentalizing or distancing from those feelings. And then they monitored for how this was going. So if they couldn't keep the non-doctor roles out of a clinical interaction, or if they couldn't keep the doctor role out of a social interaction, then that became a sign that the roles could no longer be overlapped in overlapping relationships. And then this led to a role being suspended or ended and no longer interacting with the person in that role. So here's two examples. I do have some friends and they're also my patients. There's a certain threshold beyond which I would ask them to stop being my patient or stop being my friend. So what's the threshold? Well, when I can't provide that therapeutic relationship with you because I'm there too emotionally and as a friend, and I can't be there as a doctor as well. And so I referred her. So the one role needed to be suspended when another role was interfering or couldn't be pushed into the background and couldn't be switched or separated or set aside. Now, I know many of you are thinking that this is common sense and obvious, but it's actually an exciting finding because role switching and role transitions have been studied and are being studied, and there's a decent literature on it. They're studied in terms of setting and maintaining boundaries, but also in terms of work-life balance and for working from home. Most importantly, it's something that we could teach, and it seems to be more applicable to be a mental activity that can be used dynamically and in the moment and used to monitor, whereas the boundary metaphor seems to be a little bit better for planning ahead and then reflecting back on a situation. So in this slide, I've mentioned a few key concepts that have been discussed in the literature, and we can get into these more in the question and answer if you're interested. So I'll end with a few words from participants because they capture my thoughts on for wanting to continue this research. I would love for our college to become more contemporary. And I think we have to stop pretending that this doesn't happen and be honest and open about it and say, okay, well, what can we realistically expect from humans? Yeah, they're going to form relationships with patients. Okay, that's fine. How can we help educate them and support them so that they're able to manage that? So I've tried to leave some extra time for questions and answers. Happy to go into more detail on parts of the study, but I'd also really be interested in hearing about what would be important enough to follow up with future research, what's resonating with you, what is left unanswered, and that would be useful from your point of view or in your practice. So thank you.
Thanks so much, Andrea. This is an incredibly interesting topic that I think everyone can relate to. And we're actually a little bit ahead of time. So we do have, the time to kind of churn up a bit more discussion and questions. There's some comments about, the work that has been done on boundary challenges and primary stressors in rural practice, and a comment from Tracy Morton on the fact that Tracy participated in this and the importance of this work. Maybe
Yes, thank you. Very thankful to everyone who participated, and we did some of the interviews before COVID and some during. And of course, you can't do work like this without people taking time to share their views, and then we really want to make sure that we're able to analyze this well, get it back out to the community. So we want it to be helpful for rural communities and rural practitioners. We also hope that it starts some conversations higher up and helps have more recognition for what the realities are of rural practice, and that we can stop this knowing that this is how it's done, but not having it be part of licensing exams and be something that we can openly discuss to have best practices on.
Yeah, I mean, your comment on the colleges really, it resonates with me just from the years that I was in rural practice in Alberta. It's all but impossible not to have those overlaps. There's an interesting question here regarding the plan for KT and whether there's the possibility to have knowledge translation to our provincial colleges on that and engage them and the regulatory authorities.
Yeah, so we're the first paper from the project, which interviewed physiotherapists, has been published, and we did some other analysis with some of the Masters of Physiotherapy students, and we're able to present to some of the physiotherapy college. And I think it has started. They've kind of reported back that's got them thinking about it, and it caught their eye that for how practitioners were feeling in practice, and it didn't fit with how they thought that they were feeling in practice around the paradox between what you're expected to do and what you have to do to be a good member of a community. We'd like to keep that going. I think this next paper, we're just writing it, that I presented on today, and hoping that it will also stir this up. I have to say, for knowledge translation, one of the places where we get handcuffed is if we were to try to implement this in the curriculum, you're really caught between teaching so that students can pass their licensing exams and other things that are more from a rural-centric point of view, and what might be the acceptable answer there, and then what's commonly done and what seems to be working quite well. So it's a tough spot to be in until we start to get a more broader recognition of what best practices and acceptable practices are that fit for a rural reality.
Well, it speaks to that whole concept of a hidden curriculum, doesn't it? Because those students that then go do rural rotations realize that the reality isn't quite what they've been hearing about.
Yeah, and we commented on that a bit in the paper, and it could be one direction to go. So it's often on those rural rotations where in Australia in particular, there's been reports of students coming back and saying we were confronted with these overlapping relationships. That unsettling feeling of being recognized in the bakery is one of the examples they shared, of a student, especially they're from an urban place, giggling and having fun in a bakery, and then having the staff say, "Oh, we know exactly who you are," and not being prepared for that. And really, is that that doesn't seem fair to send our students out and have them be encountering that's fairly superficial, but into of course we all know those more important and potentially devastating consequences of students not knowing that it is a different world when you're not anonymous.
Absolutely, absolutely. We've got an interesting comment from a patient citizen who's participating, asking if rural and remote communities would benefit from highlighting the variety and potentially larger scope of rural generalist practice for doctor or physician recruitment, and just reflecting on the challenges that rural communities have in recruiting healthcare providers.
Yeah, so great topic. Jill Conkin and colleagues have a paper on kind of clinical bravery, and touch on how you have to expand scope and practice differently. And I think that's really important work, and I hope they're going to follow that up. I can see a potential to help educate some of our communities about what it's like to be a practitioner in a community and how it impacts their children. Some of the things that I think if we had a better awareness that these are the habits we slip into. And we heard this from participants, is that when this is the only way you know someone and it's the thing that's at the front of your mind, that tends to be how you interact. I think someone said, if I met an astronaut, of course, I'm going to I'm going to want to talk about astronaut stuff with them, even if it's in a situation where they may not want to, and that's not the thing. And if we can help people know about these different relationships, and people need some off time and a bit of privacy, that could be an intervention that I don't think has been done yet. So yes, the next question about interviewing patients. Yes, so we have, and we've also wondered the other side to get at the overlapping relationships that have worked well for them or have been problematic, because obviously just interviewing practitioners, it's possible that they don't understand or don't have access to implications of having those overlapping relationships.
Tracy has put up the college position on this, which of course is this black and white thing that all of us who have worked in rural settings know is not the reality. One question or maybe suggestion I might have, Andrea, is often with this sort of thing, it helps to actually engage something like an organization like the college to be involved in the research itself. So rather than generating the research and trying to get it to them, you have them as part of your research team from the outset. And that may be helpful in the politics of this type of thing. Clearly, there's a disconnect.
it does seem like there's a disconnect and an unhelpful one and potentially an adverse disconnect. So I think it's a solvable problem if there was if some focus was put on it. So thank you. Yes, thank you for that. Thank you for pointing towards some of the different places that may be interested. Certainly looking for if there's partners or people who would like to get involved in some of this. Contact me. I'll put my email in the chat box so you can get it. Happy to hear from you.
It's a great topic. It's generating lots of buzz. I'm sure the buzz will continue. I do want to remind our presenters that sometimes the questions will appear after your talk. David Snadden, for example, Margaret, if you're still on, asked an interesting question to you a ways up that you may want to respond to in the chat. So we're actually ahead of time. We've got a couple minutes. So why don't we have like a 2-minute stretch? And I'm going to reconvene at like 11:29, 11:30 with our next presenter, and then we'll be synced with Zoom Room A if anybody is moving between the rooms. So we'll see you at exactly 11:30 for our next talk. Okay, well, welcome back, everybody. You're in Zoom Room B, and our next speaker is Karen Chabradut, speaking about the experience of leadership and career advancement of newcomers to Canada in small and urban and rural settings. Karen?
Okay. Hi, everyone. My name is Karen. My pronouns are she, her. I'm a second-year graduate student in the Master of Social Work program at the University of British Columbia in the Okanagan. And our research focuses on exploring the experience of leadership and career advancement of newcomers to Canada in small and urban rural settings. And as an uninvited guest, I honor the land I reside on, which belongs to the Silks Okanagan peoples. And I invite you to find out whose land you're currently on, and you can text this number to find out. That's on my slide. And before I explore our research and methods, I will discuss the background behind Okanagan settlement. So immigration in Canada continues, and it is increasing. This is primarily due to federal government encouragement to newcomers to settle in smaller urban and rural areas of the Okanagan. And recent federal government initiatives encourage settlement through the Rural and Northern Immigration Pilot Program. So newcomers who are entering Canada are entering as temporary workers, visitors, students, refugees, and are admitted under the economic category. So despite various programs and initiatives to assist settlement, newcomers continue to face challenges that impact their settlement, career advancement, opportunities, and access to mentorship. And career advancement opportunities and experiences of newcomers who are settling in rural areas of the Okanagan are currently unknown. So this image here, it's from the Rural and Northern Immigration Pilot Program, which is being facilitated through Community Futures as a partner for the program, and it aims to support newcomers with the application process, along with the immigration process and job searches. So while learning about these programs available to assist newcomers with settlement in small urban and rural areas, the immigration and settlement processes are challenging and lengthy, and leadership and career advancement opportunities are still unknown, which brings us to our research question, which is, what is the experience of leadership and career advancement of newcomers to Canada in small urban and rural settings? So our team has received funding through MidTax and the Scotiabank Economic Resilience Research Fund. And the research population that we will be focusing on includes newcomers, refugees, immigrants settling in rural and urban areas of the Okanagan, who have been referred by our community partner, SOIX. And we have two outcomes we are hoping to achieve with our research. The first one is to better understand the experiences of leadership and career advancement of newcomers in small urban and rural communities, and how these agencies structure themselves for career advancement opportunities. And our second outcome is to co-create recommendations and solutions to address leadership and career advancement for newcomers settling in small urban and rural areas. We will be using a mixed method approach, qualitative data collection through semi-structured interviews, focus groups, deliberative dialogue, demographic questionnaires, and quantitative data collection. So for newcomers, we will be interviewing newcomers and refugees in either a focus group setting or one-to-one, depending on their preference. And we are hoping to learn about their experiences firsthand with settlement and career advancement opportunities, other barriers that they might have come across, such as language barriers, what their interview processes were like, length of employment, number of jobs they've had, time spent with their current employer, employee benefits, why they chose the Okanagan, and cultural safety and support. We also hope to explore their perspective of career advancement. Have they changed or gained a new job title or increased their pay where they're currently working? And we'll also ask challenges they've experienced with credential transfers from their home country, if applicable. We also want to know what their future goals are with the agency they're currently working for. Do they want to advance their career where they're currently at? And are they able to access the opportunities to do so, such as speaking with leadership or employee evaluations? And for agencies, we will be interviewing agencies leadership within focus groups or in a one-to-one setting, again, depending on their preference. And we're hoping to learn how these agencies are structuring themselves, what their hiring processes are like, what their recruitment strategies are, onboarding, equity, diversity, inclusion, and anti-racism initiatives, and what opportunities are presented for employees for career advancement. And we're really hoping to explore how many immigrant and refugee employees they currently have, how many have changed positions since working for these agencies to an advanced level in comparison to when they first started, along with what employee retention looks like. And along with agencies, we also want to explore what training opportunities are these agencies providing for newcomers and refugees, and that would support career advancement specifically. So we are currently in the recruitment stage of our research and initiating interviews and focus groups with both newcomers and agencies. We're currently recruiting via email with a phone call follow-up, and our co-collaborator SOIX shares our invitation with newcomers, refugees who have settled in rural Okanagan areas who are invited to contact us. And SOIX is also sharing our invitation with agency partners that they are currently working with who hire newcomers and refugees. We've experienced several limitations so far. We began our research about 4 months ago and are still in the recruitment phase with 1 completed interview and 2 focus groups pending. We are actively recruiting, as I've mentioned earlier, and some of the limitations and challenges we have experienced are centered around the COVID-19 pandemic, which has led to employee and staff shortages, and the massive heat waves this past summer in BC causing work shortages and unsafe working environments. We also had forest fires this past summer with home evacuations that directly impacted small urban and rural areas of the Okanagan, and they're currently in the middle of rebuilding. And the most recent BC floods, which is still happening, and they've directly impacted many small towns and communities in the Okanagan, such as evacuations and damage to homes, and some have even lost their homes. And there's also just been a general challenge with engagement and responses from employers, agencies, and organizations. So currently where we're at, we're open for referrals for community partners, agencies, and organizations. We're also open for referrals for newcomers, refugees who are currently employed and have settled. Oops. And so if anybody has any clients that they can think of or any suggestions, we're definitely open to that. And currently our team consists of myself and Dr. Nellie Olaki, who's Associate Professor with the School of Nursing, Sherry Fernandez, who's the Executive Director of SOICS, Dr. Robert Woolard, who's the Department of Faculty Family Practice, Dr. Shirley Chow, who's the Associate Professor of the School of Social Work, and Tamasha Hussain, who is a School of Nursing student.
Thanks so much, Karen. Super important topic that, you know, many of us in medicine aren't so familiar with. I can tell you I'm familiar with it because both my parents are sociologists, and there's a large body of literature on immigration and integration and challenges. And I think it's really important work that you're doing here. One question came from Tracy Morton asking if you're open to interviewing newcomers outside of the Okanagan region, or is this study specifically focusing on the Okanagan?
So far, it's been rural areas of the Okanagan, just because that's who our community partner is, who's been sharing and connecting us with people who are accessing their services through SOICS. So as of right now, it's just been within the Okanagan.
You know, one thing that came to my mind that I was interested in asking you is, do you have any citizen partners from those communities that are helping to guide the types of things you're asking about? And if you don't, you know, that may be something that could be helpful to you in terms of the methods and what you're up to.
Yeah, so we did a test run with our questions, and we got a lot of feedback from them. And through that, we made a lot of changes and improved our questionnaire to make sure that it met the needs of the people we will be interviewing. But we don't have a direct partner, but that it could be a good idea.
But that's great that you piloted what you're working with the group.
We did, yeah.
I mean, it just comes back a little bit to, you know, this issue that we talked about with the last presentation and getting the college on board as a researcher. You know, sometimes it can help in the knowledge translation, dissemination, advocacy when, you know, the groups that could be impacted by this are involved at the researcher level. So it's one thing to consider. Just looking to see if we've got other questions. You know, another thing that came to mind for me, I was interested in asking you was, are you considering the possibility, and are you able to parse down into different experiences amongst different ethnic groups? I mean, certainly historically, we know that there's a big difference in various groups that have immigrated and integrated to Canada in terms of their assimilation. And so not all immigrants are the same, I guess, is the other way of saying it.
Yeah, right now, there's no limitation. It's just as long as they identify as a newcomer, a refugee, or an immigrant.
And I wasn't meaning to suggest there's a limitation on the enrollment, but more that you may want to look within subgroups to see if you find variability of the experience based on that. Some comments here about the linkages to communities and newcomers, so that's great to see. Any other questions or comments for Karen and her group? Maybe I'll just, because we're still ahead a little bit, I'll kind of close with one last question, Karen, and that is, where do you see this work going? Is it the hope that your findings may guide policies and interventions and improve the situation? And where are the areas that might be more amenable to that? Do you have a sense of where you might be able to influence positive change?
Yeah, I mean, our second outcome, I think, is what stands out to me the most in our research is we're hoping to be able to co-create recommendations and solutions to address leadership and career advancement challenges for newcomers. So by interviewing both, I think is really helpful, interviewing the agencies to learn more about what they are specifically doing, and then interviewing newcomers and who can share their direct firsthand experience, and then kind of combining that all to inform policy.
Fantastic. It's really important work. Okay, I don't see other questions there. So thank you again. Great job. And I look forward to seeing those results. You know, on the results front, I should mention that, you know, one of the things for all of our presenters to consider is there are different forums for the presentation of results, and the more this kind of work can be disseminated, the better. You know, one forum that I'm particularly familiar with and that would lend itself to a lot of this work is UBC Emergency Medicine Research Day, which is sponsored by the Department of Emergency Medicine and the Division of Pediatric Emergency Medicine at UBC. It's open provincially. A lot of the work here would lend itself well to presentations there. So I'd consider those of you, encourage those of you that have presentations and work related to emergency medicine to think about that. And of course, there's a similar fora for research presentations through the Department of Family Medicine. So lots of ways to get the word out, and that knowledge translation element is so important for all of this great work. We'll move on to our next presentation. Again, a presentation on sort of the realities of rural practice. We have Corinne McPhail from UBC speaking about the realities of rural pediatricians.
Hi there, I'll just share my screen. All right, does that look okay?
Looks great, yeah.
Well, thank you for inviting me to participate in this year's Health Research Exchange. I'm thrilled to be a part of today's event. My name is Corinne McPhail, and I'm a fourth-year medical student at UBC's Northern Medical Program. I'd like to acknowledge the traditional, unceded, and ancestral territory of the Lheidli-T'enneh, on which I'm very grateful to be living and working. Recruitment and retention of physicians remains a challenge in rural settings, and pediatricians are no exception. Pediatricians are specialist physicians who consult on infants and children who are acutely unwell or with complex medical conditions. They are also essential in supporting rural emergency and obstetrical care and ongoing pediatric care across the province. We know that there are significant challenges in recruiting pediatricians to rural communities, as only 8% of general pediatricians in rural practice in rural areas in Canada, while 18% of the population lives in these areas. As well, northern and rural areas score more poorly than urban areas on a number of pediatric health indicators, highlighting the health disparities and the need for more pediatric care providers. In BC, communities covered by the Rural Practice Subsidiary Agreement, called RSA communities in this presentation, are communities which meet a minimum point requirement based on size and distance from other centers, among other factors. They are essentially smaller and more remote communities within the province and are what we consider rural pediatric communities in this presentation. There are 29 pediatricians practicing in a total of 13 RSA communities, such as Terrace, Port Alberni, and Duncan. Although, as seen on the map, there's a large geographic area, particularly in the north, with few pediatricians present. Currently, little is known about the opinions and involvements of these rural pediatricians, and given the well-known rural-urban health disparities, it's essential to understand their challenges and then to implement and evaluate initiatives to support rural pediatric care. In this study, an anonymous survey was distributed electronically to pediatricians in these rural communities. 93% of eligible pediatricians responded to the survey, which focused on three main aspects of rural pediatricians' experiences: workload, locum coverage and recruitment, and involvement in education. The survey data aimed to better understand the realities of rural BC pediatricians and to establish a baseline which can be used when evaluating the impact of new initiatives. In terms of demographics, there's only one community in BC that has more than, or rural community in BC that has more than 5 pediatricians, and only 2 communities have 3 to 5 pediatricians. These 3 locations represent 45% of the rural pediatricians in BC. The other 10 communities have only single or 2 pediatricians. 63% of respondents have been in practice for more than 10 years. And when considering those in practice for more than 20 years, this applies to 37% of our respondents. Important to note is that all of the solo pediatricians have been in practice for more than 10 years. Understanding this demographic data can provide insight into workload locally to BC pediatricians. Previous studies have identified aging of current pediatricians, fewer new graduates choosing to practice in rural settings, as well as difficulty retaining those currently practicing in rural areas as key factors contributing to the challenges in providing rural pediatric care. And this is supported by the data in our study. In general, pediatricians have lower rates of burnout compared to physicians from other specialties, and they consistently report high job satisfaction. With that in mind, it was surprising to see that approximately 3/4 of our respondents reported some degree of burnout. In fact, when asked about workload, no respondents were able to or interested in taking on an increase in workload. Only 1/3 of respondents reported a good balance in their workload, and the remaining 2/3 of respondents reported wanting to decrease their workload to some degree. Interestingly, the feelings regarding workload were not correlated solely to the number of colleague pediatricians in their community, specifically with some solo pediatricians having a good balance and some in larger groups feeling overworked. In terms of locum coverage, which is having another physician cover for vacation or education, approximately half of respondents felt that they were unable to secure adequate locum coverage, and 60% felt the time and effort needed to secure coverage was unreasonable. With respect to recruitment, only one participant believed that a vacancy in their community would be filled in a timely manner, and 86% disagreed to some degree that it would be filled in a timely manner. Only 7% of respondents agreed that their community had effective recruitment strategies. And interestingly, when asked what recruitment strategies had been effective in their community, mentoring by local pediatricians was a frequent response, indicating that physicians are taking it upon themselves to actively recruit others. This non-clinical sense of responsibility and involvement in recruitment may also be contributing to the feelings of burnout and workload. Some of the other recruitment strategies included increased local exposure, word of mouth, and more formal avenues such as advertisement by the health authority for local and international applicants. Locum coverage and recruitment are important interventions that can help to address burnout and high workload. Unfortunately, as we know, recruitment to rural areas is challenging, and the pediatricians surveyed echoed these concerns. Previous studies have found that teaching can lead to higher job satisfaction, and it's been one recommendation from studies to decrease burnout. Approximately 80% of respondents participate in the education of medical students or residents, and 60% are involved in providing medical education for their colleagues to some degree. While these teaching involvements may help to increase job diversity and satisfaction, care must be taken to balance the extra work of teaching and ensure that it doesn't outweigh the benefits. It's very clear that pediatricians in rural BC are experiencing many challenges related to workload and recruitment. This local population had previously been unstudied, and the results collected will help to serve as a baseline for comparison in the coming years. There are a number of new innovative projects that have recently been implemented to address these gaps and support current pediatric providers. These include Spruce, Sustaining Pediatrics in Rural and Underserved Communities, which is a network for community pediatric providers to create strong interregional relationships and provide peer support, including locum coverage. Another new innovative program is Charlie, Child Health Advice in Real Time Electronically, which allows community providers immediate access and consultation from specialist pediatric physicians elsewhere in the province. These are both initiatives supported by the Rural Coordination Centre of BC. In order to foster interest and build competency in non-urban communities, the UBC Pediatrics Residency Program created the Community Impact Stream in 2019, available to one resident per year. The resident spends 6 months of the first year of training based in Prince George, gaining early exposure to community consulting pediatric and primary care outreach clinics. They also participate in electives with rural pediatricians. The UBC Pediatric Residency Program also offers training for graduates from international medical schools. Whereas previously there was one IMG or International Medical Graduate Resident in pediatrics per year, starting in 2022, there will now be 2 such trainees in pediatrics. These physicians hold a return of service contract, requiring them to practice in a rural or underserved community for 3 years after completing their training. And lastly, starting in 2021, the UBC Department of Family Practice is offering a 3-month training option in pediatrics as a 2-year pilot project through their Enhanced Skills program, with the goal for graduates to support pediatric care in rural BC. Since pediatricians are specialist physicians who provide consultation and advice for complex children, as well as participate in emergency care of neonates and children, they are an essential support to primary care providers in the region. It's vital that they're supported in order to ensure that these services remain available. We hope that the results from this study can aid further discussion and project implementation to support rural pediatric health. Thank you very much, and I'll end there for questions.
Thanks very much, Corinne. Beautiful picture there at the end. Where is that?
That's in Kitimat.
Nice. Okay, well, that was another great presentation and such an important topic in terms of practitioner availability throughout the province. So again, the chat is open for anybody to pose any questions. And just while we're waiting to see what comes in, Corinne, I'll ask you one thing that I found interesting. That was your finding about sort of burnout and indicators of burnout. And you made the comment that pediatricians in general, I guess, score lower on that than, for example, emergency physicians like me. My question to you is this the first time that you've looked at rural pediatricians? Is your finding specific to rural pediatricians? And is that where the difference is? And I guess the other part of the question is, how does this survey relate to the COVID pandemic and the fact that all physicians are reporting higher levels of burnout? Is it possible that that is an influence in what you found?
So I guess the first part of the question, is it why do pediatricians have lower rates of burnout, or is it rural pediatricians?
No, it's more just I'm just wanted to be sure I understood correctly that you had found that was it rural pediatricians are scoring higher than you expect for pediatricians as a whole. Is that right?
Yeah. So in general, pediatricians compared to other physicians in other specialties from previous literature shows that compared to other specialties that they have rates of burnout that are lower. But in our study, we found the rates were higher than what we would have expected compared to previous studies.
Which underscores the importance of rural work like this and this entire forum today, because that's a vantage point that isn't captured typically. My follow-up on it though was just in the interpretation. Is it possible that finding is swayed and distorted a bit by the general increase in burnout from COVID, or was this work done pre-COVID?
Yeah. So we found that actually rates of burnout and workload didn't actually change significantly with the COVID pandemic, with about half reporting that things have changed, and half, reporting that it didn't. Yeah, so the results of burnout were there regardless of COVID.
Interesting. Okay. Any other questions for Corinne? Maybe I'll just ask you one final thing. I think you alluded to it a little bit when you were talking about programs like Charlie that, are so important when you either parachute into a rural area, as I found myself doing in Bella Bella in May, or you are, permanently in a smaller community. What do you think the role is of real-time virtual support and telehealth? Do you think that's going to change this to a large extent? Do you have a sense of where that's going, or a sense of the thoughts of the pediatric community, for example, on that?
Yeah, well, I mean, I think Charlie has been really helpful in these smaller communities. Like, even in Prince George, in my own experience, I've used Charlie, and it was great for that patient case. I know in some of the smaller communities, they've actually expanded Charlie's role and have been using it as more as to be the pediatrician on call to help relieve some of the workload and burnout for the solo or smaller groups of pediatricians. So I think the role of Charlie and telehealth does have the potential and has been really helpful for some of the smaller communities.
It's an interesting issue, isn't it? It gets again into the whole politics of this issue. The same thing has happened with the Rudy program a little bit, in terms of using that as a backup when communities don't have emergency coverage, and it opens up a lot of questions about whether that's the direction we want to go and that's our solution. And there's a great comment there from Kirsten about how Charlie is a great support. So thanks so much, Corinne. That's really important work, and really nicely presented. So we'll move on to Dr. Mary Jung from UBCO, speaking about addressing the healthcare needs of rural communities, and more specifically, the implementation and impact of an evidence-based diabetes prevention program.
Great. Thank you. All right. Well, thanks so much to the organizing committee for this great amount of work, as well as for the moderator. I recognize the challenge of the role you're playing, so thanks so much. I'm just going to jump right into to start with an acknowledgement of where I'm coming from, and that's the unceded, unsurrendered territory of the Syilx Okanagan Nation. And I recognize that I'm uninvited on this land, as is the University of British Columbia on the Okanagan campus. The benefits that I directly inherit are because of colonization, and I acknowledge that myself, my team, benefit, whereas the original inhabitants and owners of this land do not. And that's why I'm really dedicated and focused on the research that I do to learn more, as well as act to decolonize the processes that we currently live in British Columbia. We all know the costs of diabetes for Canada, and so the most recent statistics from Diabetes Canada are painting a sad picture of one in every 3 Canadians living with one form or another of diabetes. We know 90% of those diabetes cases are type 2 diabetes, and that affects the individual, but of course it also affects the communities that individuals live in, as well as our healthcare in terms of financial and other burdens. Sadly, we know from our Canadian statistics that those most likely to develop type 2 diabetes are living in remote and rural communities. So this is a recent environmental scan that we did spearheaded here at UBC Okanagan with my former postdoc, Sean Locke, leading the charge. Some of the people in the room are in this paper, including Nellie Olkey. What we found essentially is that from 2001 to 2016, the incidence, the rates of type 2 diabetes as well as prediabetes were higher in interior BC than the rest of the country. And we know that those are, the reasons for that are multifaceted and certainly intersectoral and integrated together. What came up as more surprising in this environmental scan of interior BC is that there are literally no services to assist with type 2 diabetes prevention in this area, despite the urgent need. And so this is where Small Steps for Big Changes comes in, and I'm delighted to share today that we have multi-year funding from the Canadian Institutes of Health Research to adapt our program to work with rural communities within interior BC to extend our diabetes prevention program into remote and rural sites. So I'll tell you a little bit about the program. Essentially, it is an evidence-based counseling intervention that is done one-on-one, and it's been designed specifically to be brief and sustainable. We really focus on emphasizing and empowering the client or the individual to make long-lasting behavior changes, so as to not suggest this is a short-term, one-off change behavior program. As alluded to, we're focusing on reducing dependence on staff, on deliverers of the program, and we do this by introducing right from day 2 home days and a weaned schedule. So as mentioned, we use one-on-one counseling, and in that counseling deliver evidence-based behavior change techniques for both diet and exercise goals. And this is, of course, all specific to the literature on that we've produced and elsewhere on what's most efficacious for individuals at risk of type 2 diabetes. Our counseling is heavily motivational interviewing informed, so that's for many will already spark up. You'll know we're very autonomy supportive, that we empower the client or the patient in front of us. We sit back and listen to where they're ready to start the conversation rather than demand or suggest that we know the answers. Now, multi-sectoral partnerships are critical for both successful integration, implementation, and sustainability. And we're delighted to have a 5-year partnership with the YMCA of Okanagan that started back in 2016 and continuing on in the future. The YMCA of Okanagan, for those outside of the region, covers from Penticton through to Vernon and beyond, and encompasses regions that may or may not include bricks and mortars YMCA facilities. The first thing we did back in 2016 is establish a vision of partnership with the YMCA, and this has been brought forward to beyond YMCA of Okanagan to YMCA Canada now. So our goal together is to develop and sustain an effective and accessible behavior change program specific to the needs of individuals at high risk of type 2 diabetes. I won't go over each one of these, but I wanted to share that we do stick to our values when establishing new partnerships and new regions. And we're really focused on ensuring that what we're doing is adapted and relevant to the community in which we're serving. To get to this point, we've done a lot of background homework, including the development, the pilot testing, full-blown RCT funded by CIHR, hybrid effectiveness trials in the community, effectiveness scale-up in new communities. And that brings us really to this green spot here, which is where we're aiming to learn how we can better reach those in remote and rural communities. So the past 2 years has been setting us up for that. And one of the things we did to increase accessibility is really take a critical look on our own work on how we're
developing our professional development for trainers. So essentially those who are going to be our deliverers of small steps for big changes in these remote and rural communities, how can we better access and help assist them? So enter a virtual platform that you see here. This is just the welcome page for individuals that can be, existing YMCA staff. It can be volunteers. It can be community members. It can be somebody who's an alumni of the Small Steps for Big Changes program. And we really go through and work with them through a series of 7 modules on how to deliver this program. And so importantly, we start off module 1 on cultural safety and inclusivity, and really working on how we can deliver this care as best as possible. We go through what Small Steps for Big Changes is, education on diabetes, and then of course going into our MI, our motivational interviewing skills, and how to become a good listener. We don't require anybody to have past knowledge, and so this really reduces the past barriers found in other programs on demanding that somebody has 1 year experience, or they have RD experience, or they are a healthcare practitioner already. So we're proud that we can train people who do not have post-secondary education, and our research shows that their client-centered skill level is just on par with those who do have post-secondary education. Boils down to this online platform being able to train and certify people within 4 hours. Now, of course, people are welcome to go through all resources and come back to those 7 modules at all times, but the technical time to go through our interactive 7 modules is about 4 hours. Then it takes about 6 hours to take somebody through Small Steps for Big Changes. As I mentioned, those 6 one-on-one appointments, each one lasting about an hour. Again, focus on increasing accessibility. We've built a HIPAA and FIPA compliant, very safe virtual platform. And this takes care of everything from scheduling to AI notifications, to rescheduling due to inclement weather, what have you. It takes care of all of those pieces in a really smooth format that reduces the burden on deliverers. So essentially, assuming that those who are delivering the program don't have much time on their hand, we've done as best we can to reduce all of that burden. I won't go through it all, but essentially this is just a quick screenshot of what it looks like on our virtually safe site. Now this means that people in rural and remote communities, after we've trained them and certified them, can deliver Small Steps for Big Changes face-to-face, or over the phone, or through our virtual platform. It's important to note that we built a low-tech, low-high Wi-Fi needed system. So that means that you don't need a lot of internet speed to run this program. And again, like I said, you don't need they don't need to do it this way. They can do it over the phone or face-to-face, but it provides those in rural communities with an option. So this future 4-year trial has co-primary aims of implementation and effectiveness. So we really care about how this is adapted, who's adopting it, what's the dose of delivery, are there modifications we need to make, what's the fidelity of individuals who are delivering the program in remote and rural areas. Of course, critical to me is the sustainability. We want to offer this diabetes prevention program to as many people as possible. How are we doing that in the long term? And of course, that's where cost effectiveness comes in, both from the implementer's side of things, as well as the client side of reducing healthcare utilization costs. We've got lots of great materials to support those who do implement the program. And I suppose I'll end off to make sure I'm on time here as well, with just really an open invite. We're ecstatic with the funding to source this out. Well, we know, just like our multi-sector partners, that engagement with communities that we aim to serve is critical, and we won't go anywhere. We won't start anything without them. So if you're a community member who's interested in this, perhaps somebody living with prediabetes or those with experience with type 2 diabetes. We'd love to hear from you, as well as individual health region municipalities that might be interested in with us. We have not confirmed all sites in which we would love to be in, so I would welcome the an email or a tweet or anything like that, or conversation today. Thank you.
Thanks so much, Mary. Once again, we'll open the chat for any comments or questions. You know, one thing that came to mind to me, you know, when I think about program evaluation, is I think it, you know, there's an inherent sort of political element to it, in the sense that, you know, you have a program and you want to continue funding and support for it. What's the sort of knowledge translation kind of dissemination plan for this? Is it going to be helpful to the sustainability of this work that you're doing? Because it looks like a fantastic program.
Yeah, definitely built right in. I mean, we were working not just with the YMCA of Okanagan region, but YMCA Canada and now YMCA worldwide. So, for example, we have Small Steps for Big Changes expansion in Portugal. This project directly informs, well, latter, because that one started before this one. Portugal will inform the findings here, and we share those again with the board of members at YMCA Canada and beyond. You know, there's the typical formal end of grant KT, where of course we'll present, you know, in the academic sector. But I'm really interested in how can we get this knowledge into health authorities, of course, interior health authorities. I'm very interested to always have those ongoing conversations. With the pass of the Diabetes Canada Bill C-37, we know that less than 12 months away from the federal government and helping us to fund preventive diabetes programs. So, you know, we want to be right at that table as well. I think there's lots of opportunities to communicate with people in each community that we aim to serve.
You know, one sort of spin-off from that I wasn't totally clear on. This presentation was focused on the interior. Is the program available provincially, or is there the need to scale that up provincially?
Yes, good question. No, we are available anywhere. Yep, so Saskatchewan, Newfoundland, and Labrador. Just got off a call in Manitoba this morning, so I think we're right at the point of recognizing that adaptations in each and every community we serve are the first bulk of work, and we're excited that we're doing that work right now in different provinces, as well as I mentioned, in Portugal.
That's fantastic. I mean, that's the advantage, I guess, of working with an international organization like that. It's incredible, the ability to leverage this work and positively impact way beyond our kind of walls, right? Any other questions or comments, anyone? We've got about 1 minute left. I'll leave it to folks to, if things come to mind, Mary, to put it in the chat. And thanks again, great presentation. And we'll move on to Dr. Magda Aguirre, and I'm sorry, Magda, if I'm pronouncing your name wrong, with a really interesting title here, You Talk, We Listen, and advancing health economics methods in rural and remote health research and gathering local communities' knowledge and experience on healthcare decision-making.
Hi, thank you, Dr. Riyad, and good morning, everyone. I'm just gonna share my screen first. Hopefully this works for everyone. Okay. Are you able to see it? I'm just gonna have presentation mode up there. Okay. I cannot see. Okay, thank you, because I cannot see your face if you're nodding or something. All right. My name is Magda, and I'm a postdoc at UBC. I want to first thank you for being here and for listening. It's been a real pleasure to participate in this conference and learning about all the amazing research that is going on. I am actually currently in Portugal, so it's past 8 p.m. here. And if I do sound a bit low energy, it's not lack of enthusiasm. I'm just a bit tired right now. It's very close to my bedtime, but I'll make the best of my time here, hopefully. I've worked on this project while I was based in the unceded territories of the Coast Salish peoples, including Tsleil-Waututh and Squamish nations. This data was collected through Northern BC, which is actually home to 55 First Nations. So I'm here to present the work that we called, and Riyad already mentioned the long title, it's still called You Talk, We Listen, Advancing Health Economics Methods for Rural and Remote Health Research by Gathering Local Communities' Knowledge and Experiences in Healthcare Decision Making. So we want to do this by connecting technical knowledge in the Lower Mainland with lived experiences and local knowledge in the North. We also want to explore non-traditional methods of engaging diverse audiences and to create new media for people in communities to communicate their priorities to researchers, decision makers, the general public, and important audiences. By new media in this particular project, I mean art. So we did 3 photo voice projects where we asked people to bring photographs that will answer the questions that you see up there about what makes your community healthy and what are the challenges to achieve a healthy life in your community. One photo voice project was done with marginalized women at the New Hope Society and another with Indigenous women. We also did 3 focus groups and 31 interviews that included municipal officers, counselors, and healthcare decision makers. In the focus groups, we did a resource allocation exercise where we asked people to allocate tokens to services that would either expand what care is offered in the community or support access to care outside the community. So to be more specific, we asked this question: imagine that there is part of the health budget being made available just for rural and remote health, and that you are the decision maker about how this should be spent. You have 10 tokens to assign the money to each health program in the system. How would you, as a citizen, assign public resources to the list of services below? And these are examples of the services we listed. So there were some 10 to 15 services, and the tokens were not enough to fund all their services, and this was on purpose. So the object was to have people where the decision maker had and experience what might happen in the real world when we want to allocate health budgets, for example. So it's very common that we find everything important and we need everything, but we just don't have resources and money in this case to fund everything. We're now starting to look at this result, but what I will present today is more of a preliminary overview. So in terms of the strengths of living in rural and remote communities in Northern BC, nature came very strongly as something that made people feel healthy, has the sense of social cohesion and access to recreational activities throughout the year. The discussion of what are the strengths was very important to us. It was suggested by partners in the North that we took this perspective as well. And the rationale behind it is because the aim of the project is for basically outsiders to learn more about what it is to be in rural and remote settings. And so there was a constant understanding not to pass a negative perspective. The aim is not to have people moving out of rural and remote communities, it's just to have everyone living a healthy life wherever they are. And so in terms of challenges, I think these 2 photographs combine well the topics that came up as most challenging, and that I think this audience knows well about: the long distance traveled, the inclement weather conditions, and other dangerous spaces on the road, the need to leave the community, the family, the land, and the territory behind when people are sick and most vulnerable. And so, as I said, we are currently still analyzing data and thinking of ways to bridge knowledge, but I wanted to leave you with some key messages that we heard. It was clear that people have a sense of the impossibility of having all the health services at their doorstep, and the need for rationing and prioritizing when faced with a limited health budget. But if being forced to travel to receive healthcare seems reasonable, at least in some cases, participants stressed very well that the lack of financial and logistical support to do so lead to injustice in the access to healthcare. So how often happens is that only those who know how to navigate the system and can afford to travel will end up receiving adequate care. We learned that communities want to have more involvement in decision-making and better position to come up with solutions. So a simple but important example was given. So for example, the retaining programs for healthcare providers are done centrally by the health authority. And it was pointed out that the community could have more or any involvement in that process. And they could highlight what they have to offer and make it more appealing. So of course, when we think about rural or the north, we know that we're actually talking about a number of different contexts and realities, and each community is best to speak for themselves. There are already a number of important learnings for us researchers in the Lower Mainland. We might tend to see things a bit blindly and at a provisional level, so without tending to the margins and without realizing the nuances that are important, I think, for both qualitative and quantitative researchers. The methods we chose invited people that might not have been inspired by traditional research methods to participate, and they also allowed us to build relationships. We are now more sure of the fact that people have ideas and commitment to offer, that communities are already doing a lot of the efforts that in major urban centers are expected from the health authority and the provincial government. We have still a lot to learn from each other, so this team will certainly be doing more collaborations between research institutions and community members. And I think as a note, we think it's been the first project that we've done like this, and it's been eye-opening. We are seeing important results that we aim to report in an impactful way so that policymakers are engaged. Community engagement research is a step into influencing policymakers, we think, because that's a bit like how politics work, isn't it? If we're not the majority and if our voice might not be always receiving the attention it should, I think we need to create just more engaging ways of communication. And so perhaps more collaborations outside academia with artists, with community leaders, with communicators, just anything that you can think of might be a way of doing things. So on those lines, we are planning to publish a book, for example, with people's photographs, quotes, and also some commissioned artwork that goes with the message. And then we aim to distribute across the province. We also are planning exhibitions where we show the photos and we provide talk. We incentivize talks and discussions, as well as academic publications. We now have a newsletter that we're sharing with participants and people who are interested in the project and collaborators who we're engaged with. So if any of you is interested in knowing more and being part of this project and of these planned activities, please send an email. Gloria Pentaco is our contact person, and these are our faces. I probably should have said in the beginning that this team has no conflicts of interest to disclose. And just as a last word, I would just like to thank you for your time and opening up the floor to questions. I'm going to stop sharing. Thank you so much.
Thanks so much, Magda. I think you're going to get the award for presenting the latest in your time zone. You know, Ray Markham famously says something to me all the time, and it relates to the question we have in the chat, and that is, you know, you see one rural community and you've seen one rural community. You know, the question is, related to whether you've seen differences between the rural communities and their responses, or is there more consistency? I think recognizing that there's variability out there and we're not talking about complete homogeneity across all rural sites. Any comment on that and what you found?
Yes, for sure. That's such a good point that is also important to make when we're talking to people who might be outsiders, as I said before in my presentation. When we talk about rural and remote and the north, there is a risk of amalgamating everything into one thing again, as we do on provisional level and about means and averages, for example, in quantitative research, that we don't generally see what's in the margin. And there are a lot of differences. So a lot of this is in the territory, as we know. So when this project was funded, the idea was there's a lot of budgeted traveling to have us actually go into the north and to travel places and to see the differences in distances and in territory and climate and what people might face for us to learn, because we do a lot of research that is important at provincial level, but we do not know a lot about what's going on up there. And so there are also obviously differences in number of people. So we talk with mayors of big communities and also very small communities. So from 2,000 and 1,000 of people to 10,000, that's a big difference. And so the services available are different. We heard people that were very happy with the access to primary care. They say, yeah, we have a doctor, it's great, and we can see them every time. And we had someone saying, we never have a doctor. We cannot talk with anyone. And they come here and they stay for a few months and then they go. So we heard all sorts of things, and we know that saying that there are no primary care service, for example, is not a reality, because in some places there are. So maybe there are these good examples that we can know. So how did you do that? How do you get them? And so maybe communicate that to other communities. So there were quite different responses, actually.
Don't see other questions, so maybe I'll just make one last comment that kind of struck me. I was really taken with your approach. You know, the spending of the tokens is super interesting. You know, if you don't have enough to spend everywhere, where do you put that? My question to you is, it relates to your comment at the end about kind of knowledge translation and policymakers. Is there the potential to maybe be thinking of this sort of work as less siloed? You know, we traditionally think of policymakers and we think of researchers, and then the researchers do the work and try and influence the policymakers. You know, would it be helpful to maybe get policymakers on board at the onset? It seems to me that that could be. And I'll just mention one other question that Dave Snadden had, was just how many communities are in this study. So if you can address that as well, that would be great, Magda.
Sorry, I'm counting them. It's actually 17. I have a list. So I have a list of 17 communities, and they spread a bit across. But you know, some communities will have more representation than the others, and it is a qualitative study, so I don't have a representative sample, and I don't speak for everyone, of course, in northern BC.
Right. Well, that's fantastic work, and it's, you know, it's really nice to see how these various projects interrelate and give us different vantage points on the challenges and the opportunities and the frontiers that exist surrounding rural care and rural communities in BC. So nice work, and thanks for being with us so late in your time.
No, thanks. It's been my pleasure. Thanks. Thank you, everyone.
Okay, so we'll move on to our next presentation. And we have Erica Bilanger and Crystal Wong presenting on Rural Communities Have Their Say, RCCBC's Rural Site Visits Project. Crystal, I think you're muted there.
Hi, sorry, can you guys hear me?
Yeah, hearing you
Oh,
now. Thanks.
yeah, sorry about that. So welcome everyone, and thanks for joining us to listen to our rural site visits project put on by the RCCBC. So my name is Crystal Wong, and I'm a project coordinator calling in from the Musqueam, Squamish, and Tsleil-Waututh territories. And I'm also joined today with my coworker, Erica Blanchet. She's our research coordinator and data analyst from Clayton. So this is Erica and I on our respective site visit trips, and because of COVID, we haven't been able to go out, and we really miss being able to go out to community, and have felt so privileged to actually been able to meet with communities through this project. So we're funded by the Joint Standing Committee on Rural Issues, and we've been trying to meet with all 201 RSA communities. And it's really just to hear from the community members about what's working well, what's not working well around their healthcare delivery in their local communities. And we're using this information to better inform policy and program development, build stronger relationships between the JSC, RCC, BC, and rural healthcare partners. And yeah, just definitely want to focus in on the relationships that we build with those that are on the ground.
Initially, this project started out as more of a quality improvement project, but soon after meeting with communities, we realized how valuable and rich the information was, especially on the scope we were aiming for. So decided to submit an application to the UBC Research Ethics Board, and we received ethics approval through that, as well as operational approval from each of the health authorities to conduct this work. So in doing so, we started looking at the question, how can rural community engaged health services planning affect sustainable healthcare system changes? And the way we aim to really address this is take a grassroots approach and speak to community members directly within their communities and collect multiple perspectives from a variety of community stakeholders. Our approach to this work was grounded in Boland's health partnership model, where Boland argued that fragmentation actually exists in the health services delivery system, exemplified by missing links such as those between individual and community health activities and health services providers and users. Since Boland wanted to strive for unity in healthcare, he argued that unity could be created through the collaboration and partnership of multiple stakeholders. He further emphasized that approaches related to engagement in healthcare needed to be united, and identified 5 principal stakeholder groups who are essential to creating a movement towards unity in health service delivery. So similar to Boland's model, we at the RCCBC decided to take Boland's health partnership model and actually adapt it to be called the Partnership Pentagram Plus model, which includes a 6th partner known as the Link Sectors Group. This group includes partners such as those in industry, nonprofit organizations, and institutes related to healthcare and health improvement. To note, we just published in the BMJ with First Nations Health Authority yesterday on this Pentagram partnership model. So we'll make sure to leave a link in the comment section for those interested. Another approach we've included in our framework is the use of an appreciative inquiry approach, which is really a strength-based approach to bring about positive change with regards to healthcare services. Using the adapted version of Boland's model, when we go to each community, we meet with physicians, nurse practitioners, midwives, health administrators, First Nations, and community members such as municipality members, fire chiefs, paramedics, etc. So we would meet with these groups individually, and then at the end of the trip, what we would do is have a combined meeting. We would have leads from each of these groups come and attend a combined meeting so that we could hear collectively the various perspectives of healthcare services and successes and challenges in each community. So we've collected information through both focus groups as well as individual interviews. Before any material is presented to the Joint Standing Committee on Rural Issues, the notes gathered are sent back to the participants to ensure accuracy. And this was also a way of allowing participants to add, remove, or delete anything they felt wasn't reflective of their perspectives at the time. With regards to the data analysis, the data we've collected throughout this entire project is qualitative data. And so through this, we collect a number of perspectives, experiences, and views from participants in regards to healthcare, and really looked for themes across these different perspectives by taking a thematic analysis approach. We used in vivo to help organize the data, and the process has been iterative, meaning themes were constantly reviewed and refined as more data was collected over time. For our results, we do have our top 10 themes here, but I really want to focus on sharing more about our overarching themes, which is relationships, autonomy, and change over time. So the data revealed that successes in healthcare could really be distilled down to the degree of the relationships that existed, both within a community, but also with others outside of a rural community. Participants that had established trust, connection, and the ability to collaborate through relationships tended to share more healthcare-related successes compared to the communities that had strained relationships, either within their community and or outside of their community. Through this work, we have learned that relationships are truly foundational to the healthcare success of a rural community. Autonomy was viewed as another theme that connected the data together, in that community members living in rural know what's best for their own community given their lived experiences. If community members felt that they were able to practice a degree of autonomy with regards to their healthcare services on the ground that impacts their own community members, it allowed for healthcare successes to be present. On the flip side, stakeholders that felt that they didn't have a degree of autonomy or say in decision-making that impacted their healthcare services and service delivery tended to experience more challenges. And this was especially evident when participants shared accounts recalling their experiences with decision makers sitting in macro level positions in urban environments, making those top-down decisions that impact rural communities directly. Lastly, change over time was really an important contextual piece that was highlighted as an overarching theme throughout this data. And one of the biggest changes over time that had been the change in community population. Some remote and resource-based communities reported diminishing populations. However, this was much less common and didn't actually emerge as a theme than those reporting increased population growth due to young people or young families leaving urban environments to find affordable housing and retirees moving in. In addition, there's a growing tourism load in many of these rural communities. So these factors exacerbated by the expectations of care by those that have moved into the communities have impacted resources and funding for longstanding residents. For example, if there were folks that had mentioned that they moved from urban to rural, they might expect to get a family doctor right away, or they might expect that there's more resources in a community than what there actually is. So there was a bit of a disconnect that was noted. Through change over time, participants emphasized how demographic and population changes have created local concerns that the community services are not adapted to the changing context, thereby causing issues that relate to things such as capacity, staffing, patient access, service demands, funding, and manpower that do not meet the community's needs. Participants described how communities are growing in population, but services are not matching that growth. So again, resulting in a disconnect that leads to negative health service related consequences. Collectively, we noted that rural communities are dynamic, and because of their size and isolation, they are particularly vulnerable to changes like population growth, which may not be easily anticipated. Change is continual, and only those that have the ability to find ways to adapt are able to continue to deliver effective health services.
Okay, so to date, we visited 108 RSA communities and held over 380 meetings. So you can imagine the thousands of transcripts of pages we have. And just some positive feedback that we've heard, it's really just the appreciativeness from communities that we're actually taking the time to meet them where they are and understand the context of how rural they are by traveling there and experiencing their day-to-day a little bit. And so in terms of knowledge translation, we do report back to our funders biannually through update reports and focusing on specific themes, as well as sharing back with the communities through community feedback reports as well. And these are also available online on our website. We can also, upon requests, usually from other organizations, do a specialized report specific to various themes that they may be interested in, such as CPD, emergency transport, or cultural safety. And then we also have our innovations website. So this emerged because we were hearing a lot from participants, the things that they were doing to improve their local healthcare challenges, different models and initiatives and even workarounds. And we knew we needed to find a way to share this back to other rural communities. So essentially this website is a database of over 200 innovations, and it's a place where other rural community members can learn from each other's successes and maybe failures as well, cross-pollinate ideas and form new connections directly with one another. And so, yeah, so far it's been a huge success, and we're just in the process of actually going back to the original innovators to get some updates or new innovations and find a more storytelling, engaging format, and developing some videos with the communities. We've also just published our first manuscript in the BMJ Open last month, and this one introduces our unique community engagement approach, which is really a first of its kind done on this large scale. And it also focuses on those three overarching themes that Erica went over. It's picked up a little bit of media as well, and yeah, we're just excited to get this research out to our knowledge users. And then in terms of our future manuscripts, we're working on a cultural safety and racism paper right now, as well as starting one on rural transportation. So although our pentagram partnership is a very successful model, you know, we recognize it's not perfect, and especially with our engagement with our First Nations community members, we definitely think that could be improved. So given that the remaining visits that we have left, 80% of them are going to be First Nations communities, we really wanted to ensure that we're including more Indigenous ways of knowing, being, and thinking in our approach. So we've been working with a Indigenous research consultant to create a two-eyed seeing approach by taking some of our previous framework and adapting it to include more Indigenous values of reciprocity, relationships, and trust. So part of this work includes going through a train the trainer to learn about, you know, importance of pre-engagement and relationship building, modifying our meeting guide questions so none of the language is triggering, also looking at how to better sustain our relationships after our visits so it doesn't seem like we're going just in and out. So yeah, we're really excited to be doing this work, and hopefully we'll be able to do it with a few pilot communities next year. Yeah, so that's us, and this is our team, and we have a website that kind of goes over everything for the public, and all our documentation and reports are on there as well. So thank you, and open to any questions.
Fantastic presentation, and you know, it really underscores a lot of what we've been talking about in terms of how to affect change and the importance of all the sort of stakeholders, all the nodes in that pentagram plus being represented. And congratulations as well to on the BMJ Open publication. There's been some chat in the chat function sharing some links of your work and previous work on this. There is a question here regarding how you think strained relationships in rural health communities can be improved so that they're more willing to share their success stories in the future.
Thanks, Alea. That's a really great question. And, you know, I think one of the things to help strained relationships is to be able to have that opportunity to listen to others and listen to other people's perspectives. What we found is we would meet with different groups in a community that maybe felt that there was tension between two groups and but wanted the same things, wanted the same goals. And so by having those community meetings at the end to bring different partners together in the same room and be able to listen, we found that there was a lot of value in that. Crystal, if you want to add.
Yeah, no, that's great. And it's so true. And even just the value of that combined partner meeting is sometimes, the mayor had never even met the hospital chief of staff. So just to even start that relationship and create a little bit of communication sustainability for them moving forward has been super helpful in kind of those strained relationships.
That's a really vivid example, Crystal. That's amazing actually to think about. And I think for all of us that are involved in research to think about that sort of thing and think about the Pentagram Plus and, some of the other examples that have come up of the importance of partnering, for example, with policymakers from the get-go to, I think we've been increasingly better at partnering with communities and patient partners, et cetera. Maybe we haven't been as strong on the policy side. So I'm sorry to keep ranting about that, but that is one thing that I've noticed over the years. And David's made a comment that this data came from 385 interviews, which include about 750 individuals. It's really, really impressive work. So congratulations again. And I'm going to say now, just as we're coming into the last presentation, congratulations to all of our audience members for sticking with us. This is a tribute to how great this forum is, that we've still got over 30 people in the audience. So that's really exciting to see. And we're up to our last presenter. And I'll also point out, just from my own experience with Emergency Medicine Research Day, that the first presenter and the last presenter are not token things. Those are actually really important anchor points. And so it says a lot, Becky, that that you're here. And I know it's hard to go last, but it's also a real honor, and it's great to have you here. So we've got Becky Stent presenting from UNBC on improving care coordination for patients with newly diagnosed cancer in northern BC.
Hi, thanks so much for having me. Let me just get this. Okay, is that good? Everyone can see my slides?
We can see you, but we can't see your slides yet.
Okay, just 1 minute. Okay, how's that?
Yeah, that's good. And you might want to toggle to slide presenter view. Good. Yeah, we're good there.
All right. So hello, my name is Becky Stent, and I'm a graduate student at UNBC. I'm the research trainee or the research assistant working on this project, improving care coordination for patients newly diagnosed with cancer in northern BC. And this is a feasibility study. So with me on the team include the primary investigator, Erin Wilson. We have our patient co-leads, Cindy Logan and Erin Simpson, and Robert Pamet, Farah McKenzie, and Martha McLeod. And this study received funding through the 2020 Pathway to Patient-Oriented Research Award from the Michael Smith Foundation for Health Research, which I believe is now Michael Smith Health Research BC. So I'd like to start by acknowledging that I'm presenting from my home in Prince George, which is located on the traditional unceded territory of the Lheidli peoples. And I'm grateful to live and work in this beautiful part of British Columbia. The goal of this patient-oriented research project was to determine, or is to determine, at least one feasible intervention that can be implemented to improve care coordination for patients living in rural and northern BC who are awaiting diagnosis or who are newly diagnosed with cancer. In addition to selecting and tailoring a feasible intervention, we also want to determine process and outcome measures that could be used to evaluate the intervention and that reflect patient preferences and a patient-centered approach. Patient-oriented research is research that is done in partnership with patients. It aims to answer research questions that are important to patients and that can improve healthcare. A patient-oriented research project focuses on priorities that are identified by patients and that works towards improving patient-centered outcome. So for our study, we have a multidisciplinary team. We've got 2 patient co-leads on the team. We've also got health professionals, researchers, and a research trainee. The patient co-leads have been involved at each stage of the study, and their perspectives and input are actively sought whenever decisions about study activities, plans, and priorities are being made by the research team. In order to achieve these objectives, we are conducting a rapid realist review to review and synthesize available evidence around potential interventions that could be implemented in a rural and northern BC context. A rapid realist review is a useful method when the goal is to explore causal relationships involved in interventions, and when you're aiming to understand the underlying mechanisms and contexts in which an intervention occurs. We want to evaluate whether particular interventions are appropriate for our context, so that makes a rapid realist review a good option. The outcome of a rapid realist review is to develop CMO configurations, or context, mechanism, and outcome configurations. To put it more simply, a rapid realist review seeks to understand what is it about this program that works, for whom, and in what circumstances. The second part of this study is conducting one-on-one virtual and telephone interview sessions with patient participants. And the aim of these is to explore the experiences and perspectives about cancer care coordination in Northern BC as it stands now during the diagnostic interval. And the diagnostic interval refers to the period of time between when that first troublesome symptom begins or troublesome findings arise, and then the time when the patient receives their diagnosis and their treatment plan. So initially for this aspect of the study, we had intended to conduct one larger in-person workshop, but unfortunately with COVID-19, of course, we had to adapt our plans. So we've been doing these one-on-one sessions. And finally, we will be holding group sessions with primary care providers in Northern BC. And the purpose of these virtual sessions will be to present preliminary findings from the rapid realist review and also from the patient interview sessions to the primary care providers. And our aim will be to explore the proposed mechanisms and interventions with the providers in order to determine whether they're feasible within this Northern BC context. So for our study progress, where we are now, the rapid realist review is ongoing. We're currently in the data extraction phase. All of the core team members were involved, including the patient co-leads. So we started with team discussion and consensus to agree upon the search terms and the search strategy, as well as inclusion and exclusion criteria. The primary investigator and I worked closely to run the initial database search with consultation with the rest of the team as needed for decision making. For the database portion of the search, we identified a total of 1,683 records. After duplicates, we were left with 1,199 to review. So again, the primary investigator and I did the brunt of the work at this stage to do the initial title and abstract screen. We used the inclusion and exclusion criteria as agreed upon by the larger team, including our patient co-leads. With this, we excluded 1,133 records, leaving us with 66 for the full text review. At this point, we brought in the rest of the team. We worked in 3 teams of 2 to conduct the full text screens. And in collaboration with the patient partners, we decided the team, so it was a patient partner with a more experienced researcher or healthcare provider, which was something that they were more comfortable with. In cases of disagreement, team members met to discuss and come to an agreement on whether to include or exclude. We did have a 7th team member available to be a tiebreaker, but ultimately all teams were able to resolve any conflicts independently. So we completed 2 rounds of full text screening with the team, with the first round focusing on more general exclusion criteria. So sources that were not in English, focused on a pediatric population, or discussing interventions that would not impact coordination or that did not apply to the diagnostic interval. Those were all excluded, as were sources that did not describe any clear intervention or mechanism that we would be able to apply. In our second round of full text screening, we focused more intently on the context and feasibility for our region. So if sources discussed interventions that could only be delivered on site or in a local geographic area, we excluded those, as we knew Northern Health is a very big region and we had to make it work for the whole region. We also took the time to reflect critically again on whether mechanisms or an intervention were described appropriately to be included in a rapid realist review. And at this stage, we after these 2 rounds of full text screening, we were left with 41 sources. And now moving forward, we'll be doing data extraction. And again, this will be primarily the primary investigator and myself, but again, as always, with consultation with the larger team for any decision making. With our patient sessions, our interviews with patient participants are still ongoing over the next several weeks. We've currently completed 12 interviews with 3 of the team members holding these interviews, including myself. We've had challenges with recruitment during the COVID-19 pandemic, and so we've had to get a little creative with our recruitment methods, such as using social media, community pages, posting flyers within community settings, and finally having study team members share information with their personal and professional networks about the study. The overarching themes of these interviews have been to talk about overall experience of feeling heard and uncertainty during the diagnostic interval, coordination of care, process and structure, and ending with sort of a, if you knew then what you knew now, leaving it a bit open for patients to share learning that they've had in their experiences that they would pass on to someone going through something similar. And finally, we will be holding group sessions with primary care providers. These will be held in December and will be led again by 3 of the study team members, including myself. We're aiming to recruit 32 primary care providers within Northern Health, and sessions are currently scheduled for December 3rd at 12 p.m. and 5 p.m., December 10th at 5 p.m., and December 17th at 12 p.m. Plans and activities for recruitment are ongoing, and again, we've had challenges with COVID-19 that have required us to be flexible and creative. We're hoping to get a good turnout for this and be able to get input from the providers in the region about the feasibility of the proposed mechanisms and interventions that we've learned about so far. And so I would like to open it up to questions now, and I'll just leave it on this slide here with my references, and also at the bottom there's contact information there. So if anybody has any questions that we don't get to, or if you'd like to learn more about the upcoming sessions, feel free to reach out to the team.
Thanks so much, Becky. So the chat function is open if anybody wants to post anything there, and we'll leave your address up for just a little bit, and then maybe we'll toggle off of screen share.
I can even just type it in the chat box too if.
Sure, sounds good. Why don't we do that? You know, one of the things that I was really intrigued by, and I thought it's a great idea that I haven't seen done before, is to kind of out of the gate sort of say that you're to some extent limiting yourself and focusing on one intervention to implement. You know, I think that is really intriguing. How did you land on that? Where did that idea come from? I think it's really neat because it kind of focuses the group and it focuses the project in a really neat way.
You know, that was decided on before I became involved. That was in the original work plan. I think so that the main reason I'm sort of speaking for Dr. Wilson here, but my understanding of why we want to sort of settle on one main thing is that in the next stage, after this part is completed, we'd like to settle on something that could feasibly be implemented, and then look at funding and do a kind of a stage 2 of then implementing an intervention and being able to evaluate that. So that's my assumption of where that came from, was so that
I mean, it really resonates nicely as kind of being something that's, you know, feasible and impactful. So that sounded really neat to me. There's a question in the chat on whether or not you're advertising the family doc sessions through the Division of Family Practice. And the question asker had said that they hadn't heard about the sessions before today.
That is upcoming. We haven't started that yet. We've had some of the challenges we've had have been basically with getting access through Northern Health. Just, you know, with the pandemic, everyone is not only at capacity, but beyond capacity basically in terms of their workload. So that's been challenging. But that is the plan, is to go through family practice at this point, so that we, yeah, we've got limited options of how we can advertise it. So that's definitely one of the plans. And then kind of, again, using our networks and sharing the information just informally, such as this, so that we can try to get the word out.
And another opportunity to alert you to, and I'll say that for all of those participants, is the BC Emergency Medicine Network. We've got an outreach of some 1,400 physicians across the province, and now increasingly nursing members that are involved in rural emergency care. So you've got another venue there if you need it for advertising and promoting studies. One last question here, and then we'll be right at our 1 o'clock endpoint. Stu Johnson asks whether you have any early ideas about what the interventions might be. Any sense of where you might be going with this, or is it still a wide open field for you?
It's a bit early to tell, I think, but I think a lot of what we're seeing is focused on communication, I think. So it's a bit early for me to say any specific intervention, but a lot of where we're kind of seeing the gaps is where people just aren't feeling that adequate in communication, or the communication's coming later than what would have been helpful. So maybe, if someone's struggling now and would have benefited from knowing about something, but they find out about it in a month. So kind of, how can we get that communication happening where patients are feeling connected and know about what's available and know about or are able to share what they're struggling with? That seems to be a common theme, but yeah, it's still too early to have an idea of a really clear intervention.
Yeah, that certainly resonates with what I know from the one friend of mine who's in a rural setting and is going through this herself. It's sort of this black box of just wait and we'll get back to you, and you have no idea what's going on. It's very, very difficult.
Or even knowing, how long until I'm going to get a phone call. That could even, we've heard that even would help, just to know, I'm in a black box now, but in 3 weeks, someone's going to call me.
Yeah, such important work, Becky. Congratulations on this. This is really great. And thanks for being our final presenter, and congratulations to all our presenters today. You all did a fantastic job. Thanks to all you audience members that stayed with us so long. And just a shout out to RCCBC and the Joint Standing Committee on Rural Issues for supporting this event. And thanks for inviting the BC Emergency Medicine Network to be involved. I don't know if all of you were aware, but I was moderating this room, and Frank Schumeyer, also from the EM network, was moderating the other room. So it's really been a pleasure to be here with all of you, and enjoy the rest of your day.